and attentive, Diponegoro University keeps producing excellent alumnus nationally and internationally, while also contributing in the development of knowledge, technology, art, culture and exercise.
Diponegoro University now is a rising star. We have planned to become one of university in 500 world university rank. We have been continuously improving the supporting aspect such as regulation, facilities, financial system, bureaucracy management, information system, as well as quality of human resources, quality escalation of three Dharma perguruan tinggi is the primary target of UNI by stimulating the downstream of research outcomes that can be beneficially implemented for the society. We are also keen to improve the quantity of national and international academic publication, as well as the number of doctorates and professors in Diponegoro University.
Now, Diponegoro University has been improving in two important aspects of achievement, institutionally and student achievement. Diponegoro University has become a world-class university by being ranked 5th amongst almost 5,000 universities in Indonesia. Meanwhile, the students' achievement in both national and international scales of prestigious events are increasing. The vision to be an eminent research university is supported by the continued increase of research funding. The total research and civil service funding in 2018 is 123.7 billion rupiah. It consists of PNBP, the National Competition Research Funding, and Collaboration Research Funding. Intellectual property right becomes the indicator of significantly improved research. The patent consists of simple patent, patent, international patent, software and invention legal letter. To support the academic process, Diponegoro University has been improving the student facilities. Thus, the students will not only get the knowledge, but also the actualization space. Academic service, Diponegoro University has built a central computerized system that includes the service for the online study plan and online registration.
Kompetisi di Undip yang sportif dan konstruktif memacu saya untuk terus berprestasi dalam akademik maupun non-akademik.
Didukung dengan fasilitas umum dan keakademikan yang lengkap.
Sehingga membawa Undip masuk 10 besar universitas terbaik di Indonesia.
Undip berada di daerah beragam budaya yang harmonis.
Yang pastinya Undip lebih baik.
Undip lebih baik. Bagaimanapun, Undip pasti lebih baik.
Baik, baru saja telah kita saksikan video profil dari Universitas Diponegoro. Sebelum kita berlanjut, kami ingin mengucapkan selamat datang bagi para peserta yang telah hadir pada pagi hari ini. Selamat datang juga kami sampaikan kepada Bapak Dekan FKM Undip, dan juga selamat pagi kepada Ibu Moderator, Ibu Marta. Selamat pagi, Bu. Sehat, J? Kemudian juga selamat pagi kami sampaikan kepada narasumber kita pada pagi hari ini, yaitu Profesor Zaleha, langsung dari Malaysia. Good morning, Professor.
Good morning.
Yes, how are you today, Professor?
Alhamdulillah, I'm very well. I hope you are all well as well. Stay safe.
Yeah, Amin. Thank you, Professor. It's a really pleasure for having you with us today.
Thank you.
Ya. Oke, selanjutnya akan ada beberapa video profil lagi yang akan kita saksikan bersama-sama. Selamat menyaksikan.
In 1985, for the first time, we accept new students lintas jalur under the name of Public Health Study Programs or PSKM, Faculty of Medicine, Diponegoro University. Since 1987, PSKM began admitting new students for Jalur Reguler for the first time. In 1993, PSKM changed to the Faculty of Public Health based on the decree of the Minister of Education and Culture of the Republic of Indonesia. Faculty of Public Health Vision. In the year of 2024, Faculty of Public Health becomes an excellent higher education institution in the field of public health at the international level. Faculty of Public Health has the following objectives: to produce graduates who have the spirit of Pancasila, competent and have social awareness, complete, communicator, professional, leader, entrepreneur, thinker, educator, and miracle, manager, innovator, researcher, apprentice, communitarian, leader, and educator. To produce innovative research, publications in reputable national and international journals, attainment in intellectual property rights, contribution in solving public health problems. To organize transparent and accountable public health higher education, organizing cooperation and partnership in the field of three pillars of higher education. Organizational structure in Faculty of Public Health is leader, namely Dean, Vice Dean for Academic and Student Affairs, Vice Dean for Resource, Division of Administrations, namely Manager or Head of Administration, Supervisor or Head of Subdivision of Academic and Student Affairs, Supervisor or Head of Subdivision of Finance and Employee Affairs, Supervisor or Head of Subdivision of General and Asset Management. Faculty of Public Health, Managing Study Programs, Public Health Undergraduate Study Program, Superior Accreditation, Master of Public Health Study Program, Superior Accreditation, Master of Environmental Health Study Program, Superior Accreditation, Master of Health Promotion Study Program, Superior Accreditation, and Doctor of Public Health Study Program, Very Good Accreditation. The implementation of the education program in Faculty of Public Health is supported by domestic and overseas graduate lecturers. Currently, the faculty has 33 lecturers with doctoral degree, 50% of 66 lecturers with various scientific fields. They are health administration and policy, public health nutrition, epidemiology and tropical disease, occupational safety and health, environmental health, biostatistics and population, and health promotion. In the learning process, Faculty of Public Health supported by education staff as much as from various backgrounds, competencies, and professionalism. Infrastructure, building and laboratories. Building A, the Dune Building, 2 floors. Building B, lecture rooms, 3 floors. Building C, lecture rooms, 2 floors, meeting room, At the Building D, Secretariat Room, Lecture Room for Graduate Programs, Computer Laboratories, Public Health Laboratories, Unit Room of Faculty Support, and Hall. Building E, Student Activities Room. Building F, Student Activity Center, Praying Room, and Canteen. Building G, Lecture Room and Secretariat Room of other graduate study programs, Library, Archive Room, and Study Activities Room. Other facilities, Canteen, Futsal Field, Basketball Field, Volleyball Field, and other sport facilities. To support student learning process, Faculty of Public Health has 6 laboratories. Laboratory of Basic Biomedicine, Laboratory of Environmental Health, Laboratory of Occupational and Safety Health, Laboratory of Epidemiology and Entomology, Laboratory of Public Health Nutrition, and Laboratory of Audio-Visual Aids. Faculty of Public Health has international programs since 2016 in order to support Diponegoro University to be the world-class university. The programs are International Conference of Public Health, Tropical and Coastal Development, and summer course followed by students from many countries. Student activities are Residency, Partner Village, and Outbound. Superior programs are Study Center of Environment and Toxic Materials, Study Center of Neglected Tropical Disease, Study Center of Reproductive Health and HIV/AIDS, Study Center Public Health Nutrition, and Study Center Health Policy.
Baik, itu dia sudah kita saksikan bersama-sama video profil dari Fakultas Kesehatan Masyarakat Diponegoro. Nah, sebelum kita mulai acaranya, saya ingin kembali menyapa peserta yang sudah hadir pada pagi hari ini bersama kita. Terima kasih sudah bergabung bersama kita pada pagi hari ini. Baik, Bapak Ibu sekalian, acara kuliah umum Visiting Profesor akan segera kita mulai. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera bagi kita semua. Puji syukur kehadirat Tuhan Yang Maha Esa yang telah memberikan rahmat, hidayah, dan taufiknya, sehingga kita dapat bertemu walaupun secara virtual dalam acara Visiting Profesor dengan tema Preventive and Promotive Efforts in Nutrition to Reach a Healthy Pregnancy in the Adaptation Period for New Habit COVID-19 Pandemic. Kami ucapkan selamat bergabung kepada seluruh peserta yang telah hadir pada pagi hari ini. Telah hadir bersama kita narasumber kita pada pagi hari ini langsung dari Malaysia, Profesor Dr. Zaleha Abdullah Mahdy dari Universitas Kebangsaan Malaysia. Good morning, Profesor. Dan juga telah hadir bersama kita pada pagi hari ini Dekan Fakultas Kesehatan Masyarakat Universitas Diponegoro serta moderator kita Dr. Marta Irene Kartasurya, MSc PhD. Selamat pagi, Ibu Moderator.
Pagi.
Baik, sebelumnya akan kami bacakan tata tertib pada pagi hari ini. Baik, Ibu Bapak, mohon izin untuk melaporkan jumlah peserta kita hari ini. Dari hasil form registrasi, tercatat sebanyak 130 orang peserta yang hadir baik dalam Zoom maupun juga YouTube live streaming. Jadi, acara ini tidak hanya dapat dilihat di Zoom meeting, seperti yang kita lakukan seperti hari ini, namun juga bisa melalui YouTube live streaming. Baik, ini dia peserta terdiri dari 130 orang dengan kategori 50,9% berasal dari non-undip dan 49,1% berasal dari mahasiswa dan mahasiswi undip, seperti itu. Baik, peserta terdiri dari mahasiswa S1, S2, S3, dan alumni Fakultas Kesehatan Masyarakat Universitas Diponegoro, serta juga kalangan umum, seperti itu. Diharapkan semua peserta dapat mengikuti acara sampai selesai. Baik, akan saya bacakan tata tertib pada kegiatan pagi hari ini. Yang pertama, peserta wajib mematikan atau mute audio device-nya. Kemudian yang kedua, bagi peserta yang akan bertanya kepada narasumber, dapat mengajukan pertanyaan langsung di kolom live chat, dan bagi yang melalui YouTube juga dapat melalui kolom live chat. Kemudian yang ketiga adalah link materi dan pengisian form kehadiran dan evaluasi akan diberikan pada saat acara berlangsung. Kemudian yang terakhir adalah pengisian form kehadiran dan evaluasi di akhir acara. Seperti itu. Nah, akan saya bacakan juga susunan acara pada pagi hari ini. Yang pertama adalah pembukaan, kemudian menyanyikan lagu Indonesia Raya, kemudian pembacaan doa, dilanjutkan dengan sambutan sekaligus pembukaan acara Visiting Profesor. Kemudian yang kelima adalah paparan dan diskusi yang akan dibagi dalam 3 sesi. Yang keenam adalah pemberian sertifikat kepada moderator dan main speaker oleh ketua panitia. Dan yang terakhir adalah penutup. Baik, Bapak Ibu sekalian yang kami hormati, sebelumnya marilah kita bersama-sama menyanyikan lagu Indonesia Raya.
Indonesia tanah airku, tanah tumpah darahmu. Di sana aku berdiri, jadi pandu ibumu. Indonesia kebangsaanku, bangsa dan tanah airku. Marilah
Baik, Bapak Ibu yang kami hormati, terima kasih sudah menyanyikan lagu Indonesia Raya bersama-sama. Kemudian juga sebelum kita mulai acaranya, marilah kita berdoa bersama agar acara pada hari ini dapat berlangsung dengan lancar dan baik. Berdoa dipersilahkan. Baik, berdoa selesai. Selanjutnya, pelaksanaan acara visiting profesor akan kami serahkan kepada moderator, yaitu Dr. Irene Kartasurya, MSc PhD, untuk memandu acara ini. Sebelumnya akan kami bacakan CV dari moderator. Sejenak. Ya, moderator kita pada pagi hari ini adalah Profesor, mohon maaf maksud saya Dr. Irene Kartasurya, MSc PhD. Beliau lahir di Sukabumi tanggal 26 Juni 1964. Saat ini beliau merupakan staf pengajar dari Fakultas Kesehatan Masyarakat Universitas Diponegoro dan mengampu beberapa mata kuliah seperti biomanik dasar, gizi daur hidup, gizi ibu dan anak, gizi olahraga, dietetik masyarakat, penentuan status gizi, serta gizi pesisir. Berikut adalah riwayat pendidikan beliau, yaitu beliau lulus sarjana di tahun 1990 dari Fakultas Kedokteran Universitas Diponegoro. Kemudian beliau pada tahun 1994 hingga 1996 melanjutkan pendidikan master beliau di Cornell University New York di bidang nutrition. Kemudian pada tahun 2001 hingga 2006 beliau melanjutkan studi doktoralnya di the University of Queensland, Australia di bidang yang sama, yaitu nutrition. Baik, beliau banyak melakukan penelitian tentunya, dan beberapa penelitian beliau dalam 3 tahun terakhir seperti faktor risiko gagal tumbuh baruta usia 6-23 bulan di Kota Semarang pada tahun 2018, kemudian juga pengaruh intervensi kader kunci terlatih atau KKT terhadap peningkatan kinerja pemantauan status gizi balita di Posyandu Kabupaten Demak pada tahun 2019, dan yang terbaru adalah scale up peran Desa Wisma sebagai promotor sangkil dalam deteksi dini dan pencegahan malnutrisi pada tahun 2020. Baik, selain penelitian, beliau juga banyak melakukan pengabdian seperti pendampingan ibu hamil dengan kekurangan energi kronis oleh kader pada tahun 2015, kemudian juga ada pelatihan bidan sebagai bekal pendampingan penggunaan bumil kit di wilayah kerja Puskesmas Lebdosari pada tahun 2018, dan yang terbaru adalah pelatihan aktivis Dawis dalam pemberian ASI eksklusif di wilayah Puskesmas Genuk Kota Semarang pada tahun 2020. Selain penelitian dan pengabdian, beliau juga memiliki banyak sekali publikasi ilmiah, beberapa di antaranya seperti The Prediction Model for Low Birth Weight in Batang District, Central Java, Indonesia pada tahun 2017. Kemudian juga ada Saponin Maintaining and Dose Determining in Carica Papaya Leaf Cookies as a Breast Milk Booster tahun 2019. Dan yang terbaru adalah Analysis of Neonatal Service Management in the Community Health Center in a Central Buton Regency pada tahun 2020 melalui International Journal of Multicultural and Multi-Religious Understanding. Baik, itu adalah CV dari moderator kita pada pagi hari ini. Langsung saja kita sapa moderator kita pada pagi hari ini untuk Dr. Irene Kartasurya. Waktu dan tempat saya persilahkan.
Terima kasih. Terima kasih untuk kesempatannya. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Terima kasih terutama untuk Prof. Zaleha yang sudah hadir pada acara visiting profesor ini. Kami sungguh berbahagia dan sungguh menghargai kesediaan beliau untuk mengisi acara visiting profesor ini. Ya, untuk menyingkat waktu, kita mulai saja acara visiting profesor ini, Preventive and Promotive Efforts in Nutrition to Reach a Healthy pregnancy adaptation in adaptation period for new habits COVID-19. Ya, jadi pada hari ini kita akan mendengarkan presentasi dari Prof. Zaleha yang jauh dari Malaysia, akan mempresentasikan mengenai upaya-upaya nutrisi, ya, upaya-upaya gizi. Nanti audiens bisa mendengarkan. Tapi sebelumnya tentu saja kita perlu berkenalan dulu dengan Prof. Zaleha ini. Ya, baik. Saya akan memperkenalkan Prof. Zaleha. Saya akan membacakan CV beliau. Apakah sudah terlihat? Ya. Good morning, Profesor Zaleha. Let me introduce you to the audience. Ya, Profesor Dr. Zaleha adalah nama lengkapnya Profesor Dr. Zaleha Abdullah Mahdy. Beliau lahir di Perak, di Malaysia tahun 64, sama ini tahun kelahirannya dengan saya. Ya, beliau sekarang adalah sebagai Profesor and Senior Consultant in Obstetric and Gynecology, Faculty of Medicine, University Kebangsaan Malaysia. Ya, beliau mendapatkan bachelor degree-nya from University Kebangsaan Malaysia, dan pada tahun 92 sampai 96 juga mendapatkan master degree dari University Kebangsaan Malaysia. Selanjutnya pada tahun 94 sampai 96 beliau mendapatkan doktoratnya, gelar doktornya dari University of Newcastle, United Kingdom. Ya, di Inggris sana ya. Jadi beliau juga sudah doktorat sejak mendapatkan gelar doktor sudah sejak tahun 96, ya, sudah cukup lama. Kemudian beliau punya Google Scholar Index yang tinggi, ya, H-indeksnya 19 dengan citasi 1743 dan I-10 indeksnya 29. Beliau juga sudah memulai karirnya itu sejak tahun 1989, ya, di Kuala Lumpur General Hospital. Selanjutnya juga beliau masuk di dalam Department of Urology Kuala Lumpur General Hospital, dan pada tahun 92 sebagai trainee lecturer pada Department of Obstetrics and Gynecology UKM. Dan selanjutnya beliau juga pernah di Princess Mary Maternity Hospital and Department of Obstetric and Gynecology, Royal Victoria Infirmary, Newcastle upon Tyne di United Kingdom. Ya, kemudian beliau juga masih bekerja di sana sebagai Honorary Research Associate di Department of Obstetric and Gynecology, University of Newcastle upon Tyne di UK. Kemudian beliau kembali ke Malaysia masuk ke Department of Obstetric and Gynecology UKM. Kemudian terus berlanjut menjadi Associate Professor and Consultant sebagai konsultan di UKM Specialist Center juga. Dan beliau sampai sekarang sejak 2006 sampai sekarang beliau adalah Profesor and Senior Consultant di Department of Obstetric and Gynecology UKM Medical Center. Ya, dan beliau juga sudah menerima banyak prizes and award, ya, yang sudah diterima, yang pada tahun 2005 juga beliau mendapatkan Best Clinical Research Article from Developing Country dalam artikelnya yang berjudul Tocolysis in Term Bridge External Cephalic Version. Ya, dan artikel ini dimuat di IJGO Ya, itu adalah suatu official journal of the FIGO, International Federation of Gynecology and Obstetrics. Ya, dan this article was cited in the RCOG Green Top Guideline on Management of Breast Presentation. Berarti ini suatu ya karya yang luar biasa. Kemudian pada tahun 2005 juga beliau mendapat dalam
Halo, Assalamualaikum. J report Bu.
Scientific Meeting of the RCOG, beliau juga mendapatkan third best poster presentation. And the study has now been published in Acta Medica. Jadi beliau juga menulis ya artikelnya yang hasil penelitiannya tentu saja the role of palm oil in and vitamin E in the prevention of pregnancy-induced hypertension and preeclampsia. And juga beliau mendapatkan Sultan of Perak's Birthday Honors List, and beliau juga mendapatkan Outstanding Service Award in tahun 2000, kemudian shortlisted finalist for Young Investigator Award dan Wellbeing Research Grant from the Royal College of Obstetrician and Gynecology. Beliau juga aktif di dalam research and consultation and development dalam banyak hal ya. Antara lain adalah virtual reality application in clinical training, diagnosis and therapy. Kemudian beliau juga aktif di dalam aerial navigation and geofencing for medical intervention, dan juga mendapatkan project juga di dalam implementation of first trimester screening and prevention of preeclampsia. Kemudian assessing drone transportation of blood and blood products in massive obstetric hemorrhage. Wah, luar biasa menggunakan drone ya, sudahan ya, transportasi dari blood ini, darah. Kemudian a prospective observational study on use of dinoprostone in the medical management in first trimester of miscarriage. Juga beliau dan menemukan juga clinical formula for estimation of birth weight. Ya, wah, ini luar biasa juga ya. Kami juga sangat tertarik di bidang itu. Kemudian individual customized antenatal growth chart monitoring using micro application in improving perinatal outcome, a collaborative study of UKMMC and Birmingham Perinatal Institute. And developing communication ethic framework in doctor-patient discourse towards professional medical practice. Ya, beliau juga aktif di dalam hal etik, ya, etik pekerja, etik pasien dokter. The prevalence of generalized anxiety disorder among pregnant women, dan juga assessment of efficacy of a mobile application in eliminating misdiagnosis of group B streptococcus infection and neonatal complication at early onset. Juga beliau banyak lagi ya, beliau aktif di banyak hal, the prevalence of obsessive compulsive disorder, prevalence and risk factor for group B streptococcus, and juga ada soal terapi celecoxib versus mefenamic acid in the treatment of dysmenorrhea, dan juga comparison between iberate folate and zinc-copper in treatment of iron deficiency anemia in pregnancy. Ya, jadi membandingkan antara pemberian besi folat dan zinc-copper, dan mungkin ini banyak mikronutrien tergabung di situ. Ya, jadi banyak sekali sudah beliau aktif sekali di dalam bidang di bidang ini. Obstetri, ginekologi, maupun juga di bidang etika, maupun juga beliau di bidang berkaitan dengan gizi juga banyak karya beliau. Ya, luar biasa. Baik, selanjutnya.
Mohon maaf, Ibu Marta.
Ya.
Alhamdulillah ini Pak Dekan sudah bergabung bersama kita pada pagi hari ini.
Ya.
Untuk selanjutnya mungkin kita akan ke Pak Dekan terlebih dahulu untuk membuka acara Visiting Profesor di Fakultas Kesehatan Masyarakat Universitas Diponegoro ini. Kepada yang terhormat Dr. Budiono SKM Menkes, waktu dan tempat kami persilahkan.
Bismillahirrahmanirrahim. Yang terhormat Our Honorable Dr. Hadir, or we with the nickname Mrs. Didit, and Mrs. Irene Kartasurya PhD on the Moderator, and our college, and also the participant. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah.
Waalaikumsalam.
Alhamdulillah Rabbil Alamin. Today we conduct the webinar with the title Preventive and Promotive Effort and Nutrition to Reach Healthy Pregnancy in the Adaptation Period for New Habits COVID-19 Pandemic. Thank you very much for Profesor Dr. Zaleha Abdullah Mahdy from Universitas Kebangsaan Malaysia, who will give some knowledge and experience regarding to this topic. I appreciate for your joining in this webinar. It's a very great opportunity to me to welcome you to this event. Like Mrs. Marta said, that you have so many experience and publication, and also the innovation in the field of the nutrition and the development of the children, and also in the pregnancy woman. It's very important to us to know more about this topic, or this research topic or publication. Universitas Diponegoro has many program. I mean international program, such as this event, visiting professor, also guest lecture, and international conference and summer course. And we also welcome you to conduct the collaboration, research collaboration, for example, and also publication. And I think it's very important to students to increase the knowledge and experience. So I hope the student will active in discussion and many experience and also information regarding to this topic. Thank you very much for your attention. With your permission and Allah Subhanahu wa Ta'ala, this event I officially open. Bismillahirrahmanirrahim. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. I'm sorry because I already had activity with our rector. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Pak Dekan.
Terima kasih Bapak Dekan atas sambutannya. Untuk selanjutnya akan kami serahkan kembali kepada moderator, kepada Dr. Marta, dipersilahkan.
Terima kasih Rizky yang sudah, dan terima kasih juga Pak Dekan sudah memberikan sambutannya. Dengan demikian acara ini sudah resmi dibuka oleh Pak Dekan. Baik, kita lanjutkan. Saya persilakan Prof. Zaleha untuk mempresentasikan. Ya, please, Profesor Zaleha, the time is yours for your part 1 presentation. Oh ya, sebelum mulai, maaf sebelumnya kami beritahukan kepada para peserta untuk kalau mau menanyakan sesuatu silakan Anda bisa langsung saja di kolom chat menuliskan pertanyaannya, bisa dalam bahasa Indonesia ataupun dalam bahasa Inggris. Presentasi akan diberikan oleh Prof. Zaleha dalam bahasa Inggris, tetapi nanti juga mungkin bisa diselingi juga bahasa Indonesia. Ya, dibagi presentasi ini akan dibagi dalam 3 part ya, part 1, part 2, and part 3. Di antara part 1 kemudian Anda akan diberi kesempatan bertanya, ada break sebentar, kemudian ada kesempatan bertanya. Demikian juga dilanjutkan dengan part 2, 20 menit presentasi, sekitar 30 menit, maaf, 30 menit presentasi, kemudian pertanyaan, presentasi dan pertanyaan. Oke. Thank you for your attention. Now it's time for you to present the part 1.
Terima kasih Dr. Martha. Thank you very much. I would like to share screen before proceeding with my lecture. And before that, I would like to thank Universitas Diponegoro, Dr. Nugrahani, Dr. Martha.
Sama-sama. Selamat datang, Prof. Welcome to my conference.
The Dean, the administration, and the Secretariat for all the hard work in putting together this webinar. Inshallah, I will try my best to impart whatever little knowledge that I have. I'm very sure that all of you are much more knowledgeable than me in terms of nutrition, because you are specifically trained in the area of nutrition. I come from obstetrics and gynecology, so I will be presenting the obstetrics perspective of nutrition, inshallah. I most welcome the sharing of information and knowledge in this area, and perhaps there are areas where we can work together in future in terms of research and sharing knowledge.
Thank you very much.
Can you see my screen?
Yes.
Yes.
Right. So as has already been alluded to by the moderator, Dr. Mata, and the Dean, the topic for today is preventive and promotive efforts in nutrition to reach a healthy pregnancy in the adaptation period for new habits in COVID-19 pandemic. I must say that a lot of my work on nutrition, I do it together with the public health consultants in my university as well. So there is a very close working relationship between my Department of Obstetrics and Gynecology with the public health consultants in my university. And that is how we come up with many of the research that the results of which I'm going to reveal to you. And in part 1 of my lecture, I'm going to cover maternal nutrition in the COVID-19 era, specifically covering what happens with the COVID-19 pandemic in terms of maternal nutrition. Now, basically, the nutritional needs in pregnancy, the recommendations remain the same. It does not change with regard to the pandemic. What is recommended is to consume a balanced diet with daily micronutrient supplements. I do believe micronutrient supplements are very important, particularly in developing countries like ours, where people tend to consume more macronutrients, and micronutrients tend to get ignored or neglected. And it is important for pregnant women to seek help for low and high gestational weight gain, as well as for any anemia, the cause of which is almost always either iron or folic acid deficiency. That's the most common. And not to forget a lot of daily physical activity, at least 20 to 25 minutes a day. And it's good to see that you have all maintained a lot of refresher courses and all that in antenatal care as well as in nutrition, even during this pandemic period, from the videos that you showed just now. And there is one thing that perhaps many do not realize during this pandemic, the issue of emotional eating. This is a paper published by Chinese researchers covering Wuhan as well as areas outside Wuhan with regard to the COVID-19 pandemic in relation to emotional eating. The hypothesis is that concerns about COVID-19 pandemic can cause a rise in the emotional eating score among pregnant women, and this can lead to changes in the diet consumption and changes or variations in gestational weight gain compared to before the COVID-19 pandemic started. When they look at the composition of food that was eaten by the community under lockdown during the pandemic, there's not that many changes except for certain things. For example, as you can see here, there is a lot more increase in the consumption of eggs as well as vegetables. And there's also quite a bit of increase in the consumption of cereals, because possibly that's the easy thing to get during the pandemic when people are in lockdown. Very notably is that there is a great decrease in the consumption of fish and seafood, because these are fresh food that is not easy to get when people are under lockdown. The availability, accessibility to these foodstuff are probably limited during this area. And similarly with meat and poultry, there is also a significant decrease in the consumption of these food material. And so what they found was that there's quite a significant increase in the prevalence of emotional eating, and those with high emotional eating scores end up with a lot of consumption of cereals. As you can see here, cereal consumption is increased, and also there is a significant decrease in the consumption of fish and seafood, okay, among those who are with a high emotional eating score. And what does that translate to in terms of gestational weight gain? They found that those with high emotional eating scores have a tendency to have excess weight gain. All right, although this is not specific to the areas where the pandemic was most prevalent in the area of Wuhan, but even those outside Wuhan, the emotional eating score is increased, possibly because of anxiety related to the pandemic. And what is the importance of gestational weight gain? Now, if the weight gain in pregnancy in total is more than 18.2 kilograms, generally that is considered as excessive weight gain. And there are many complications that can accompany excessive weight gain. For example, macrosomia, a baby who is large for gestational age which means that there will be a higher cesarean section risk for such pregnancies. And there is also increased risk of respiratory distress syndrome or RDS and assisted ventilation of the newborn in mothers with excessive weight gain, some of which will be related to the development of gestational diabetes mellitus. And there's also increased risk of neonatal infections, hypoglycemia, neonatal ICU admission, longer hospital stay for the mothers as well as the babies, failure to initiate successful breastfeeding, which is very important. And I think we also note this just by simple observation among us. Those with excessive weight gain, they tend to fail to initiate successful breastfeeding. And also, they are more inclined towards early termination of breastfeeding. So these are significant impacts of excessive weight gain. And there are various recommendations as to what constitutes an ideal weight gain in pregnancy, and it has been changing throughout the years. In the 1940s, for example, the recommended ideal weight gain in pregnancy is less than 9.1 kilograms. I suppose at that time, most people were undernourished and underweight. In the 1970s, it was encouraged to increase weight gain above 11.4 kilograms in order to prevent preterm birth, as well as to prevent growth restriction. We shall see that, you know, growth of the fetus is very much related to the protein calorie intake of the mother. And in the 1990s, the Institute of Medicine in US started to become the main institute that recommends what gestational weight gain should be in pregnancy. And it was recommended to be 11.5 to 16 kilograms. And basically, it has stayed about the same for women with normal pre-pregnancy body mass index. The UK, on the other hand, has got a different recommendation, which they suggested in 1991. But subsequently, I think worldwide, the medical community has stuck to the Institute of Medicine US recommendation, the latest of which is from 2009. So this is the recommendation in 2009, the IOM recommendations. And although there is a wide range of weight gain which is compatible with good clinical outcome, gestational weight gain appears to vary according to ethnic population. And for East Asians, for example, there is a slightly different recommendation. What is normal weight, what is underweight, and what is overweight. And we shall see in a while that this determines what varies from the norm. But what is important also to note is that any departure from the normal are consistently associated with adverse outcome irrespective of the ethnic population. Meaning that, for example, for East Asians, we may have our own set of criteria. What is normal weight, underweight, and overweight. But what is important is if we go according to our own population's criteria, then we come up with the same percentage or prevalence of people who are underweight and overweight as compared to the IOM criteria, which is adopted by the West, by US and by Europe. Okay, and no matter which criteria is used, in each of the population, those who do not gain enough weight and those who gain too much weight, they are exposed to exactly the same problems in terms of obstetric outcome. So this is a systematic review and meta-analysis of maternal and infant outcomes in more than 1 million women worldwide. And what was concluded from this paper, which was published quite recently, is that women in the US and Western Europe have higher pre-pregnancy BMI and higher rates of gestational weight gain above guidelines compared to women in East Asia. However, if you were to use regional BMI categories in East Asia, as I've mentioned to you just now, as I've explained, rates of gestational weight gain above guidelines are similar across the 3 continents. And if the gestational weight gain falls outside the guidelines, it is associated with adverse outcomes, irrespective of which region you're talking about and which criteria is used, as long as the criteria is the appropriate criteria for the population concerned. So this is what I meant. Like for example here, you'll find that the gestational weight gain below average, according to guidelines, and above average. If you look at US and Europe, this is the percentage. Now for Asia, if you use regional BMI, then it is about the same, similar to USA and Europe, which uses the IOM criteria. So using regional BMI criteria is important. If you use overall criteria, then we will be below the average because we are lighter than those people in US and Europe. Okay, similarly with the increased or excessive weight gain, you can see that the gestational weight gain above average, US, Europe, this is according to IOM guidelines, is the same as in Asia, also 51%, if in Asia we use the regional BMI. We cannot really adopt the IOM BMI. And if you look at the odds ratio for pregnancy outcome by region, the outcome parameters that are looked at here is small for gestational age, preterm birth, large for gestational age, which is similar to macrosomia, and also cesarean section, which usually increases because of the increased prevalence of LGA and macrosomia. So if you look at this, you'll find that those with gestational weight gain below the guidelines, no matter which guideline is used by that particular population, okay, you'll find that there is significantly increased prevalence of SGA and preterm birth. Whereas if, similarly in Asia here, okay, but if you look at excessive weight gain, what increases is the LGA and macrosomia, and as a result of which the prevalence of cesarean section or the risk of cesarean section also increases. So I hope that is clear. And now, when we see that emotional eating gives rise to problems with nutrition during COVID-19, we are reminded that mental health of these mothers are very important. So much so that people have now come up with even mobile apps to help pregnant women with health advice during the coronavirus lockdown, including some apps for to calm the mothers down and to provide better mental health care. This is a simple survey that we have done in UKM among 415 antenatal and postnatal women during the restrictive movement control order or lockdown that we had between March to end of May recently. And what we found is actually almost 90% of these mothers demonstrated negative psychological response to the COVID-19 pandemic. Significant risk factors for these mothers to develop these anxiety feelings is when they are young, aged below 35, and nulliparous mothers, meaning that this is their first pregnancy. So what we can conclude is that COVID-19 pandemic resulted in high levels of maternal anxiety, especially among young and first-time mothers. And what should be recommended is psychological support services and some education about the pandemic in order to pacify these mothers during the, particularly during lockdown periods when they cannot get out of their house and have very limited communication with people who matter to them. And what are the maternal concerns or challenges regarding COVID-19? One is they are worried about risk of infection. And if they get infected, they will be isolated. That is what happens in Malaysia. I'm not too sure about Indonesia, but here, all patients who are COVID-19 positive are hospitalized. And the worry also extends to the effect of the pandemic on their unborn child. And during the movement control order or the lockdown, there is also social isolation of these mothers from significant family members. For example, they cannot go back to their kampung to visit their parents. They worry about the parents' well-being, as well as they are cut off from actually getting support, physical support from their mother, for example. I'm sure, you know, in our culture, whether it is in Indonesia or in Malaysia, during pregnancy, the pregnant woman usually get a lot of support physically, mentally, emotionally from their mothers, advice and so on. So this is deprived of them during the lockdown. Although they can communicate by telephone, I think it is not the same as having your mother with you during that time. And the economic impact is also important. Loss of job and income to many people, in the private sector, whether it is themselves, the pregnant mothers themselves, or their spouse, their husbands. They may be losing their jobs and their incomes. And the other thing which is also important is visitation rights if they are hospitalized. We have restricted hospital visitation here during lockdowns or during the movement control orders, where even now, since the conditional movement control order has been imposed, most hospitals only allow either one visitor or none at all. And there will also be no accompanying person allowed in the clinic and in labor, not even their own husband. Although before this, we were actually a husband-friendly hospital, and we allow the husband to accompany the mother during labor, but not during the lockdown. So all this caused a lot of anxiety to the pregnant mothers. And in terms of mode of delivery during the COVID-19 pandemic, although generally most guidelines globally recommend that the mode of delivery follows obstetric indication and maternal level of compromise if they are positive for COVID-19. However, the Malaysian guidelines advocate cesarean section for all COVID-19 mothers in order to reduce risk of infection to the attending healthcare workers, because we do not have negative pressure labor wards or negative pressure operating theaters. Okay, so these mothers who are diagnosed with COVID-19 positive, if they go into labor, we would perform cesarean section on them, unless delivery is imminent. If they come to us already, say, you know, almost fully dilated, then we will allow them to deliver normally. If not, if they are only like 3 centimeters or 2 centimeters, you know, when they come to us with labor pains, then the recommendation in Malaysia is to perform cesarean section on these mothers. Now, the other issue is also rooming in and breastfeeding. Generally, the guidelines in the world recommend no restriction except in the presence of maternal compromise. However, in Malaysia, it is advocated that the mother and baby should be separated after birth if the mother is COVID-19 positive until the mother's swab test becomes negative. So this is also another source of anxiety among our mothers. This is the guideline that I was talking about. And as you can see, it is clearly stated here that mother and baby friendly policies for person under investigation, even if they are suspected and the swab test has not come back yet, then at the designated hospitals, these policies or services are suspended to reduce the risk of exposure. Patients in labor are offered cesarean section as mode of delivery until more evidence on safety of vaginal deliveries is established. Okay, and breastfeeding is also deferred until confirmatory diagnosis excludes COVID-19 infection in the mother. So our policies are quite strict about this. And this is the flow chart. If the mother is a person under investigation or COVID-19 positive, then we offer cesarean section. Okay, if she is not in imminent delivery but in labor, she's active labor, all right? And only if she is imminently going to deliver, then we allow them to deliver normally with universal precautions to the staff. We are very, very concerned about our staff. So far, alhamdulillah, we have not had any healthcare workers diagnosed to be positive due to infection because of contact with a PUI or a confirmed case of COVID-19 positive. And again here, you can see that there are concerns of prolonged exposure of staff during the entire intrapartum period, and the risk of aerosol exposure is significant, especially in the second stage of labor when the patient strains or pushes. So because of that, coupled by the fact that almost all centers do not have negative pressure equipped labor suite, person under investigation should be offered a cesarean section as mode of delivery unless delivery is imminent. And if the patient refuses cesarean section, despite counseling, the refusal of treatment forms should be filled, and this should be documented in the clinical notes. So we are very strict about that. And just for your information, in general, the breastfeeding policies everywhere else around the world does not conform to what we are practicing. It is still advocated that rooming in is allowable and breastfeeding is allowable for COVID-19 positive patients. In this day and age, I think it's very difficult to say who is right and who is wrong because of the evidence which keeps changing from day to day with the increasing number of infections with COVID-19. Now, emotional eating leading to increased gestational weight gain is one aspect of the COVID-19 pandemic. However, on the flip side, on the other hand, you may have in many parts of the world, particularly in underdeveloped countries, people who are undernourished because of the effects of the pandemic. You can see here, there are many reasons for that. One is deprioritized contacts and compromise enablers, which means that many of the policies and practice before this that were gearing towards improvement in nutrition have had to be held back because of the pandemic. A lot of the funding that was channeled previously to healthcare services, including increasing the quality of nutrition, had to be rechanneled to fight the COVID-19 pandemic. Okay, and on the individual level, there is reduced income and limited resources, as I have mentioned just now. Even in Malaysia, loss of income and loss of jobs among patients and their spouses. Poor feeding practices and food insecurity because of limited or interrupted food supply chain, and this drives food insecurity during the pandemic. There is interrupted school and community nutrition programs, and also counseling services because of limited communication and face-to-face or physical contacts between individuals, between the healthcare workers and the community. And there is limited care and restricted health services because of the lockdown, unhealthy household environment where these the people in the community have to put up with now because of the lockdown. They are confined to their household, which may not have good amenities, even water supply and all that. Well, having said that, even in Malaysia, quite a number of places just recently had limitation in water supplies. So that can lead to difficulty in maintaining good sanitation and as well as nutrition during the COVID-19 period. And poor dietary intake, higher disease incidence with longer durations, and also higher risk of intergenerational transfer, meaning that, if there were bad aspects of healthcare that prevail within the family from generation to generation during the COVID-19 pandemic, this is maintained or passes on because of the limited communication between the household with the outside world. So only families can, practice things among each other, and they are cut off from the rest of the world physically. And all this means, compromised maternal and child nutrition, leading to stunting, wasting, underweight, small for gestational age of fetuses carried by pregnant mothers, and maternal and child micronutrient deficiencies, which is very important with very significant impacts, as you can see later. So there's a lot of steps that can be taken on a public health level to mitigate the undernutrition impact of COVID-19, but it needs a lot of political will, and the non-health sector has to step in as well. For example, economics and education, and family planning is the other issue as well. The access to family planning, particularly physical family planning methods, for example, access to material, like for example, pills, IUCD services, or even condoms may be limited during the lockdown. And this can lead to a lot of unplanned pregnancies, for example, with the respective impact on nutrition. And this is as comparison, chronic starvation is not something new to the global community. During the Second World War in the Netherlands, for example, there was what is famously known as the hunger winter, when the war was rife and nutritional rations reduced, even in terms of protein calorie intake. There were 6 months of famine with generalized malnutrition, where the calorie intake dipped down to 450 calories per day because of rationing of meals. And As a result of that, it was found that the median birth weight of babies reduced by 250 grams, and this showed an increase after the famine, after the war. Although perinatal mortality rate did not change, malformation rate also remains unchanged, and mental performance of the offspring remain unchanged. Now, preeclampsia was reduced. I wonder whether this had to do with, a reduction in excessive gestational weight gain, which is a possibility. And all this also translates into increased non-communicable diseases, obesity, diabetes, and cardiovascular diseases among the offspring in later life because of the increased prevalence of SGA, small for gestational age, as well as low birth weight. And this has got to do with the early programming, what we know now as Barker's hypothesis. So this is one thing that we can perhaps predict to happen in years to come after the COVID-19 pandemic is over. So in conclusion, the effects of COVID-19 on maternal nutrition is that although nutritional requirements remain the same, but there are people who are predisposed to overnutrition because of emotional eating. And on the other hand, there are also mothers as well as children, particularly children who are exposed to undernutrition, particularly in underdeveloped countries because of reduced accessibility to adequate supplies of nutrition. Okay, so with that, perhaps I would stop here. That's the end of part 1. I will stop my slide sharing for a while, and I will be able to take any questions that may have come in at this point. Thank you.
Yeah, thank you very much, Prof. Zaleha. The part 1 is over. You have presented very well. I just will make a resume for the other audience. For the audience, yeah, I will translate it in Indonesian, the resume. Yeah, so we can see that in part 1, maternal nutrition in COVID-19 era, jadi berat badan yang berlebihan, peningkatan berat badan yang berlebihan dalam masa pandemi ini ternyata juga berkaitan tetap ya baik berlebihan ataupun berkekurangan akan juga tetap meningkatkan dampak, ya, meningkatkan dampak jeleknya. Misalnya kalau kekurangan akan mengakibatkan bayi yang lahir kecil atau prematur, SGA dan preterm. Nah, kemudian kalau berlebihan juga akan mengakibatkan makrosomia dan cesarean section tentu saja akan meningkat. Kemudian juga berarti ya tetap harus dalam tetap menggunakan guideline yang ada, ya, penambahan berat badan harus sesuai dengan pedoman yang ada untuk di setiap wilayah. Kemudian mental health ternyata juga itu dipengaruhi, ya, kesehatan mental seorang ibu dalam masa kehamilan itu sangat terpengaruh di masa COVID-19 ini. Dalam masa pandemi, terutama pada penelitian yang dilakukan, ternyata terutama yang berdampak pada wanita ibu hamil yang muda dan ibu hamil yang pertama kali melahirkan, hamil yang pertama. Ya, jadi perlu pelayanan psikologi dan edukasi tentu saja untuk mencegah dampak yang tidak diinginkan. Kemudian juga kalau di Malaysia, bagaimana manajemen persalinan itu dilakukan, semua yang diduga menderita COVID-19 maupun yang sudah terkonfirmasi menderita COVID-19 itu diseksio, ya, diseksio semuanya menggunakan cesarean section karena tidak ada ruang ruang bertekanan negatif di dalam untuk persalinannya. Ruang persalinan yang bertekanan negatif tidak ada. Itu yang digunakan kebijakan yang dilakukan di Malaysia. Demikian juga soal breastfeeding, soal memberikan menyusui itu tidak dilakukan. Jadi deferred ya, ditunda sampai betul-betul negatif ya, betul-betul si ibu terbukti negatif. Baru dilakukan menyusui, pemberian ASI. Kemudian ya selama COVID-19 ini berarti faktor risiko untuk mengalami undernutrition itu sangat meningkat. Ya, tadi juga disampaikan bahwa misalnya asupan yang meningkat itu asupan cereal, asupan telur dan vegetable, tetapi asupan makanan segar seperti seafood dan fish itu sangat menurun. Dan juga ada pengaruh emosi ya, pengaruh emosional eating score, sehingga karena karena ada tekanan, ada stres lah ya di dalam situasi itu, sehingga meningkatkan biasanya meningkatkan penambahan berat badan. Kemudian juga faktor resiko undernutrition itu meningkat, maka juga harus dipikirkan nanti ke depannya bisa mengakibatkan juga peningkatan NCD, non-communicable disease atau penyakit tidak menular, meningkat sesuai dengan terjadinya hipotesis. Sesuai dengan hipotesis Barker yang ada, dan juga resiko untuk undernutrition itu meningkat, maka perlu dilakukan mitigasi. Sudah harus dilakukan mitigasi, misalnya peningkatan pelaksanaan program KB keluarga berencana ditingkatkan, diupayakan sehingga meminimalkan dampak dari COVID-19 ini. Demikian itu ringkasan dari bagian pertama dari presentasi Prof. Zaleha hari ini. Selanjutnya kita akan break sebentar. Silakan audiens mempersiapkan pertanyaan, atau kalau sudah ada pertanyaan silakan ditulis. Ya, kita break sebentar. Kami juga memberi kesempatan kepada Prof. Zaleha untuk istirahat sebentar.
Terima kasih Dr. Marta. That was a very good summary of the first part of the talk. Alhamdulillah. You did that summary very well, and I think there is a question in the chat box.
Okay.
Dari Widya from Universitas Brawijaya Malang. Really appreciate your important explanation. I wonder, does Malaysia Ministry of Health have a guideline to deliver nutrition education to pregnant women during this pandemic? Do you have a website or special platform or guideline to convey the education to ensure the reliability of education across the country? Many thanks for your explanation. Right, very good question. And I think, Widya, you just woke all of us up from our slumber. You know, we have been very much concerned about the COVID-19 pandemic itself, that I think we are starting to forget that all these other guidelines for long-term healthcare management are also very important. To be honest with you, I think right now we do not have a specific guideline to deliver nutrition education to pregnant women during this pandemic. In fact, I think as many of us know, many of the healthcare continuous education or continuing education activities have got to stop during the pandemic, especially if it involves face-to-face interaction. And a lot of the courses and seminars have to be brought online, but of course there are limitations to the online interaction. You know, some of the things which involves practical aspects cannot be participated adequately online. We can only demonstrate, but the participants have to do the practice by themselves. which is also quite challenging. No, to be honest, we do not have at the moment any online nutrition education to pregnant women during this pandemic, but we hope to restart all these activities latest by the new year. We are still planning for that. There are some other activities which have gone on, but mostly are related to the immediate management of the pandemic itself. For example, webinars on management of pregnant women affected by COVID-19, and also some webinars on emergency management of pregnant women.
Thank you. Okay. If is there any more question? Yeah. Oh, one more.
One more, yes.
Yeah, one more question.
Yeah. If I may read the question.
Yeah. Do you understand? Yeah.
I think I should understand. Inshallah, I will try. Tidak banyak beza antara bahasa di Malaysia dan di Indonesia kan, kecuali beberapa istilah.
Yeah. Thank you, Prof.
Kita semua sama satu perdu, one origin of ethnicity. Ibu yang tinggal bersama orang yang dituakan, ibu kandung atau mertua banyak menghindari asupan atau makanan amis dan mengurangi minum pada masa nifas. Ya, betul. Dengan alasan mengganggu kesihatan ibu dan bayi. Di masa pandemik ini sudah dilakukan edukasi secara mobile, tetapi hal itu tetap dilakukan. Apa yang harus dilakukan menghadapi hal tersebut? Terima kasih. Yes, this is something which is a big problem in our communities, right? Whether it is in Indonesia or Malaysia, we share the same culture. I remember as a medical student, we used to go visiting to house to house together with the midwives to see how the postnatal women are taking care of themselves. And I remember there was one house where the postnatal woman, the daughter-in-law, actually ran away from home, ran away from the mother-in-law's house because she couldn't tolerate the kind of nutrition that was served to her every day. You know, they were only allowed to eat some rice with which is boiled quite dry, and with some dried fish and some black pepper. That was all. You know, there was no vegetables, nothing at all, and only 2 glasses of water, which is actually quite deficient, you know. And because of that, she had reduced breast milk production as well, the poor girl. And so the mother-in-law was very tearful and told us, you know, she was very sad. Daughter-in-law has run away, you know, but we had to then, you know, the midwife counseled her and told her not to be too upset about it, but also tried to educate her about, you know, what nutrition should be like. I think it's not easy. It's a big obstacle that we have. I'm sure Dr. Mata has come up with it, face this as well in your day-to-day practice in Indonesia, right, Dr. Mata? And
experience this.
Yeah, and particularly I think the midwives on the ground who visit them at home. And I think it is important to educate not only the pregnant woman, but also the significant people in the family, particularly the matriarchal side of the family, the mother and the mother-in-law. Maybe they should be brought into the, maybe special nutrition courses should be held for them rather than only the pregnant women. You know, during the time that the women are pregnant, that is possibly one of the things that we can do. But definitely it's going to be more challenging during this COVID period. We hope that with better education of the mothers, we now, Dr. Mata, myself, are becoming the generation of mothers and mothers-in-law, right? So hopefully, you know, with better education of women, this problem can be gradually overcome, but it will take a long time. Thank you.
Thank you very much, Professor Zaleha. Yeah, now what do you think? Is it we can continue to the second part, or do you need a break?
No, I'm okay.
Oh, yeah.
Yeah.
Okay,
If
so
audience is all right, I'm okay to continue.
yeah.
I shall now share my screen again.
Yeah.
And we'll proceed to the second part of my talk. This is a bit longer. I think it will take a bit more time compared to the first part, because this I will touch on every single aspect of macronutrient and micronutrient, the different types of or elements in nutrition that we have, the different vitamins and so on.
Yeah, that's fine. You can have your time, please.
Thank you, Dr. Mahdy.
Yeah.
So I will proceed to the next part, which is maternal nutrition requirements. As I have mentioned just now, this does not change because of the COVID-19 pandemic itself, although it is very important at this juncture for us to improve maternal nutrition in order to make the mother's health stronger, in order to ward off the COVID-19 infection. Because as we know, any infection, if individuals are compromised in terms of immunity especially, they will be more prone to develop the infection. So with better nutrition of the mothers, we hope that less mothers will develop the COVID pandemic disease itself. And or even if they develop the disease, at least they will not succumb to it, and they will be either asymptomatic or have a mild course of disease. What I will cover during this segment of the talk is some aspects of macronutrients, which is basically protein, energy, nutrition, calories and proteins, and the micronutrients, which will take up a lot more of the part 2 of my talk, because I will be covering each of the elements. So calories and protein wise, as we know, pregnancy requires an additional 80,000 kilocalories of energy, and most of this are to be taken in the second half of pregnancy. Therefore, the recommended increase is about 100 to 300 kilocalories per day. And it is important to take note that nutritional requirement, whether it is macronutrients or micronutrients, tend to change with the progression of pregnancy. What you will need more in the first trimester may not be the same as what you need in the second and third trimester, and also in the postnatal period. With regard to calorie intake, this increased requirement is partly compensated by reduced physical activity. So less energy is expended by the mother because she moves slower and does less manual work compared to when she's not pregnant. Therefore, the actual increase in calorie intake that is required may not will be compensated with this reduction in the physical activity. And whenever calorie intake is inadequate, what would happen in the mother's body is that protein is metabolized rather than spared for the fetus, for the fetal growth and development. So it is important to realize that if the calorie intake of the mother is not enough, the protein in the mother is broken down, and therefore there will be less protein available for the growth and development of her fetus. And with regard to protein, 1,000 grams of protein is deposited in the second half of pregnancy, which means that 5 to 6 grams per day is required for this deposition, a lot of which will be used for building blocks in the fetus. And most proteins should be supplied from animal sources, which is a better source of protein. For example, from meat, milk, egg, cheese, poultry, and fish. And so, you know, the reduction in the intake of protein, like what we saw just now, happened in China, in the intake of fish, poultry, and all that is not, and meat is not very healthy, although there is some compensation by increase in the egg intake. I suppose egg is easier to disseminate, you know, to be made available in the community because it is not as perishable as fish, poultry, meat, and so on. And milk and dairy products are almost ideal sources of nutrients, especially protein and calcium, for the pregnant or the breastfeeding mother. Now, it is important to be aware that macronutrient in terms of protein and energy intake, if it is provided as a supplement for those who are not taking enough protein and energy, it can reduce the risk of IUGR or fetal growth restriction, okay, significantly. Okay, this is evidence from meta-analysis. And although the height and gestational age of the babies, meaning that the gestational age at delivery is not significantly affected, all right? But the growth of the baby, the gross growth in terms of the birth weight can be affected significantly by protein energy malnutrition. And for example, in rural Gambia, somebody did a study giving them supplementation with high energy groundnuts, kacang, yeah? Okay, snacks to the mother, and this significantly increased the birth weight of the babies. So this is one way of overcoming protein energy malnutrition in deprived communities. Now, on the other hand, for communities who are not deprived of protein and energy, we have to be careful about maternal sugar consumption. In this big study involving more than 32,000 nulliparous women in Norway, it was found that foods with a high content of added sugar increases the risk of preeclampsia in these nulliparous pregnant women. Food which have naturally occurring sugars are quite different. Okay, for example, food with sugar from vegetable or fruits, they are associated with a decreased risk of preeclampsia. Okay, so it is important to educate the mothers not to take, for example, beverage like Cokes and all that, you know, all this sugary drinks, okay, during pregnancy. Okay, it should be limited because too much of those kind of food intake can cause them to have high blood pressure during pregnancy, and it is very significant and important because of the impacts of preeclampsia on the maternal, not only health and well-being, but also life during pregnancy. We know that preeclampsia is one of the big causes of maternal death all around the world, especially in developing countries like us. So, favorable associations, nutrition with favorable associations in terms of reducing preeclampsia, SGA, preterm delivery, and congenital malformations are those with, for example, probiotic milk products, you know, naturally, natural foods, okay? And vegetables, fruits, oils, whole grain, and water, okay? intake of those should be increased during pregnancy. However, on the other hand, food with adverse associations with preeclampsia, SGA, and preterm delivery are those which are high in processed meat and fats, refined bread, and also sweetened sugar beverages, and salty and sweet snacks. Okay, and all these PCBs, dioxins, mercury, of course, are bad. Okay, and also if there is lowered intake of fruits and vegetables, that is also bad in pregnancy. Okay, so intake of fruit and vegetables should be increased. Now, I would move on to micronutrients. As we all know, micronutrients are nutrients that are required in small amounts throughout life, which is why they are called micronutrients. This includes organic acids, like acetic acid, citric acid, choline, taurine, and so on, as well as trace minerals. Of note, the important ones, those which are we are very well aware of, are things like calcium, iodine, iron, zinc, and vitamins. B complex, for example, vitamins A, C, D, and E. You know, those are the most important or outstanding ones for us. Others are like long chain polyunsaturated fatty acid, like DHA, for example, omega-3, omega-6, which are a lot in fish oil, as well as flavonoids. I think flavonoids is something more newer to many of us. This is a lot of it is available in fruits and vegetables. Flavonoids. Why is micronutrient important? Many of the micronutrients are cofactors of metabolism or metabolic activities in our bodies, and they are also catalysts to enzymes, important enzymes in the metabolic processes of our bodies. And these are the micronutrients that I'm going to touch on: calcium, vitamin D, A, C, and E, iron, folic acid, zinc, DHA, flavonoids, and quite important is multiple micronutrient supplementation. I would touch a little bit on the deficiency and supplementation of some of these micronutrients. Right, calcium, a very important micronutrient, not only for pregnancy, even for non-pregnant women and men. It can be quite important even in cardiovascular diseases prevention. Right, this is a study that we did in Malaysia. I'm quoting a lot of studies in Malaysia, but I do believe that a lot of the habits, nutritional habits and so on in Malaysia are quite similar with those in Indonesia, I would think. And which is why I would like to share this with you. We looked at a group of pregnant women in 2 tertiary hospitals in Malaysia, and we found that the median calcium intake is only 725 milligrams a day, although the recommended daily requirement of calcium is 1,000 milligrams a day. And if we were to exclude deliberately taking milk and calcium supplements, if it's only daily dietary calcium intake, it was only less than 500 milligrams a day, less than half of what the woman would need in a day. And even when you include milk and calcium supplement, more than 1/3 of these women consume less than 600 milligrams calcium in their daily diet. 600 milligrams calcium was what was at one point in a WHO study considered as the benchmark, below which it was considered that the intake of calcium was grossly inadequate or insufficient for that population. And the adequacy of the daily calcium intake, surprisingly, was not influenced by maternal age or even the income or job status of the mother. and it was not influenced by the ethnicity or the parity of the mother as well, how many children she has had and so on. Okay, so it is like across the board, it's just the same. The calcium intake of Malaysian women is just inadequate. So this is the paper that we published in the Journal of Obstetrics and Gynecology Research. And elsewhere in the world, other studies have proven that calcium supplementation during pregnancy is associated with reduction in risk of gestational hypertension, preeclampsia, as well as neonatal mortality and preterm birth in developing countries. This is a study by Prof. Buta, and this is a meta-analysis of studies from developing countries, including 10 randomized controlled trials in this review. Okay, so it is important to note that calcium supplementation during pregnancy is of utmost importance. And I think many of us have not really practiced this. We tend to give a lot of iron and folic acid, but we forget the calcium. And again, another paper published in the Journal of Maternal, Fetal and Neonatal Medicine in 2012. The results of this meta-analysis demonstrate that additional intake of calcium during pregnancy is an effective measure to reduce the incidence of preeclampsia, particularly in populations at high risk of preeclampsia due to ethnicity, gender, age, high body mass index, and in those with low baseline calcium intake like ours. And this is the recommended calcium supplementation by WHO. Now, the thing is, even up until now, the actual real ideal dosage and frequency of calcium supplementation during pregnancy is not quite very well known yet. And some would say that it is important from 20 weeks gestation until the end of pregnancy, meaning that in the second half of pregnancy. I suppose that is based on logic, because this is when there is a lot of building of the bones in the fetus in utero. However, there is a study, multi-center trial that is being done by Canada, looking at calcium supplementation from even before pregnancy and comparing with those who take it after 20 weeks to see whether there is any difference. But in general, it is considered that any calcium supplementation less than 500 milligrams per day in pregnancy is not adequate. So increasing calcium intake during pregnancy does make a difference in reducing the risk of pregnancy-induced hypertensive disorders, which are very important. This is an important cause of maternal death in our countries. And increasing calcium intake also reduces preterm birth, neonatal death, as well as it has a positive effect on maternal and fetal bone health. We just celebrated our Osteoporosis World Health Day recently, so this should come to mind. And we should remember that the whole body mineral bone content of the fetus increases at 32 to 33 weeks and at 40 to 41 weeks. And the greatest fetal calcium accumulation happens in the third trimester, which is why it is most important to increase the calcium intake in the second half of pregnancy. Although it is still important, perhaps, in the first half for the maternal health as well. And right, so that's about calcium. I would now move on to vitamin D, which is also another area which has been under the spotlight recently of healthcare workers. Now, vitamin D deficiency is more common than what we think. The shortage of vitamin D among pregnant women increases the risk of preeclampsia, gestational diabetes mellitus, preterm birth, as well as small for gestational age very, very significantly. And in the quest of trying to find when is the best timing to give vitamin D supplementation during pregnancy, this group B et al. Has come up with this meta-analysis. They find that overall, actually, it doesn't matter whether you give it before you initiate the supplementation of vitamin D before 20 weeks or after 20 weeks. Okay, at the end of the day, vitamin D supplementation reduces the risk of SGA, small for gestational age, in the offspring. And I think this is very important. Sometimes we forget how important this is in view of the impact of Barker's hypothesis. Okay, this is the future of our generations. All right, if we do not correct this, if we do not make attempts to reduce the prevalence of small for gestational age, then in the future, we will be facing a lot more adult individuals with non-communicable diseases. You know, diabetes, hypertension, and heart disease, okay, in later life. Okay, so that will drain our healthcare resources. So one thing that we do right when the mother is carrying those babies now can save us from a lot of healthcare costs in the future. In terms of dosage, okay, it looks like a dosage of less than 2,000 international units per day of vitamin D is enough to significantly reduce the risk of small for gestational age among pregnant mothers. Overall, it also still results in a reduction in a significant reduction in SGA when you give vitamin D supplementation. But a smaller dose seems to be already adequate. In terms of a more difficult outcome measure, fetal and neonatal death, okay, it is quite difficult to prove that from this meta-analysis that vitamin D supplementation significantly reduces this lethal outcome. However, in terms of dosage, yes, there is significant reduction in fetal and neonatal death brought about by a small dose of vitamin D of less than 2,000 international units per day. Okay, it does reduce fetal and neonatal death significantly. So I think we have enough evidence to say that vitamin D supplementation during pregnancy is important. And in an observational study that we did in an urban district in Malaysia, we found that despite all the abundance of sunlight in our country, you know, and I'm sure it's the same in Indonesia, there's a lot of sunlight everywhere being tropical. The prevalence of hypovitaminosis D, that means low serum vitamin D levels, is 90.4%, which is quite staggeringly shocking. You know, these are young women. The mean age is 28 years old, so no reason for them not to be able to go out there in the sunshine. And independent predictors for this low level are those of Malay and Indian ethnicity. I wonder whether it's because of the darker skin. So less ultraviolet lights can be absorbed into our skin because of the melanin, you know, and also higher educational level. You know, the higher your education level is, the lower your vitamin D in the serum. And perhaps this is because those who are well educated, they tend to be in the, they tend to work indoors. Less of them do manual work outside the home, you know. So these are like office workers and ourselves working in, you know, tertiary education and so on. You know, we are less exposed to sunshine, and perhaps we take less diet that has got enough vitamin D as well. For one thing, in Malaysia, we find that the eating habits is such that a lot of women do not like to take milk, for example, and any dairy products, milk, cheese, and so on. So that is one thing which is quite outstanding in terms of our diet habits. I don't know whether it's the same in Indonesia. And one study that we did recently found that vitamin D level was positively correlated with gestational age at delivery. Okay, and vitamin D deficiency is associated with increased risk of spontaneous preterm labor among our population. So routine supplement of vitamin D is possibly beneficial in reducing preterm births. And we know that preterm births increases the healthcare costs because of NICU admission, NICU management, and so on. And of course, it increases the risk of neonatal death. Now, very interestingly, vitamin E, I will touch on vitamin C as well because there are some studies in the world that combine vitamin C and E. To start with, there was a Western study published in Lancet many years ago that says that combined vitamin C and E, the VIP trial, produced disappointing results, okay? With a huge sample size of more than 2,000 high-risk pregnant women, they found that giving vitamin C and E in the form of soya bean vitamin E, it is important to note that tocopherol, this is quite different. Okay, there are two main types of vitamin E, tocopherol and tocotrienol. Okay, and tocopherol is not as good an antioxidant as tocotrienol. Okay, tocopherol comes from things like soya bean, for example. Okay, when they did a randomized control trial comparing a combination of vitamin C high dose with vitamin E in the form of tocopherol, they found that the incidence of preeclampsia is just about the same in the two arms of the study. And therefore, their conclusion was that it was not beneficial to give vitamin E and C in combination in pregnancy. And there was also increased incidence of severe preeclampsia as well as adverse fetal outcome like fetal growth restriction. Okay, so that was quite disappointing. However, in a study that we did in Malaysia using palm oil vitamin E alone, without combination with vitamin C or any other vitamin, okay, we found very promising results. This was in 299 low-risk primi gravida. Their risk factor was being primi gravida, okay, and we specifically started the supplement before 16 weeks gestation, like what they do with aspirin now. I'm pleased to say that actually we were the first group to start giving supplements in order to prevent preeclampsia before 16 weeks gestation. I remember when I went to attend the ISSHP European Congress in 2004. We were actually doing this study at that time. And there was actually a very strong reason from a paper by Hermida et al. That says that any prophylaxis that you want to give against preeclampsia must be given before 16 weeks gestation in order to be effective. So that was the basis of us starting this supplementation before 16 weeks gestation. And I went up to the speaker at that time during the ISHP conference when they were talking about the VIP trial, and I told them, since you all give this supplementation, a lot of them after 16 weeks and before 22 weeks gestation, that could be one of the reasons why this is not effective. And I told them that we were actually in the middle of doing this study where we gave supplement of vitamin E before 16 weeks gestation. And we actually put up the interim analysis of the study as a poster at that time. And final results from this study was what we presented at the RCOG World Congress in Egypt in 2005. And we compared the intake of tocotrienol-rich fraction, or TRF, which is actually basically vitamin E from palm oil, 100 milligrams daily versus placebo. The placebo is just superolin, which is the background substance for both the types of capsules on the trial arm as well as the placebo arm. And in the TRF arm, we found that the risk of preeclampsia and pregnancy-induced hypertension, meaning that preeclampsia and combined with gestational hypertension, all these incidents are significantly reduced. Okay, the odds of developing preeclampsia is reduced by 70%, and the odds of developing pregnancy-induced hypertension, that is combination of preeclampsia and gestational hypertension, is also very much reduced. So preeclampsia, sorry, the overall is reduced by 97%, and preeclampsia and gestational hypertension, which is pregnancy-induced hypertension, is reduced by about 75%. Okay, and so this is what we published. Well, we initially published the outcome as a bivariate analysis in Acta Medica, and it did not show any significant difference between the two, although the p-value was very near to significance. It was 0.058. And subsequently, what we did recently was that we did a secondary data analysis, because the definition of preeclampsia and PIH has changed. It was changed by the ISSHP in the year 2014 and again in 2018. So we thought, why don't we reanalyze the data that we still have intact with us of these 299 patients using this new criteria. And we found that it was significant prevention of preeclampsia as well as PIH, okay, with multivariate analysis. All right. So we have now submitted the paper for publication. So the thing about vitamin E, of course, I think it excites people in Malaysia as well as Indonesia, because we are the biggest producers of palm oil in the world. And it would be good if we can benefit, particularly our own women who suffer a lot from preeclampsia, by giving them vitamin E supplementation from palm oil. Right, moving on to vitamin A. There is something interesting that I would like to point out. Now, it was observed that supplementation, now some people give vitamin A supplementation only after birth, okay, to postnatal women. But it has been shown that supplementation provided before birth, that means during pregnancy, even before pregnancy, okay, before pregnancy and during pregnancy and in the immediate postpartum period, results in additional improvement of lung function evaluated in the the offspring, the children that resulted from these pregnancies in their preschool age. Okay, although there was no changes in the cognitive and motor development, but lung function is improved. And there was also improvement in terms of less risk of gestational night blindness in the mother when the supplementation of vitamin A was given during pregnancy. Now, very interestingly is this paper on H1N1 vaccine response in mothers when given vitamin A during pregnancy. It was found that weekly maternal vitamin A supplementation during pregnancy and postpartum not only increases the breast milk vitamin A concentration, but it also enhances prenatal H1N1 vaccine responses in the mothers. Okay. Therefore, I think if we were to extrapolate this to the present pandemic, you know, it would seem that vitamin A supplementation can possibly or potentially improve the immunity of the mothers and the newborn by improving the antibody levels. Okay, whether they are vaccinated or not. It is a possibility. Perhaps somebody would take this up as a study. Now, a very important mineral element in our diet is iron. As we know, body iron requirement increases in pregnancy. It increases by twofold in the pregnant woman compared to the non-pregnant woman. And the need for iron in pregnancy increases from trimester to trimester. In the first trimester, for example, the requirement for iron is only 0.8 milligrams per day. But in the third trimester, the requirement increases to 7.5 milligrams daily. All right. And the net iron loss from the body of a pregnant woman in one pregnancy, as a result of just one pregnancy alone, is 630 milligrams, and this has to be replaced before the next pregnancy in order to prevent iron deficiency propagating from one pregnancy to another, particularly if there is poor spacing of pregnancies and poor intake of iron from one pregnancy to another in between pregnancies. It's very important. And it is also important to be aware that of all the dietary iron that we take, the absorption is only between 10 to 15%. If I take 1 gram of iron in my diet, only 100 milligrams is absorbed. If I take 100 milligrams, only 10 milligrams is absorbed into my body. The rest are all discharged as waste product. Okay. And heme iron from meat is better absorbed than non-heme or vegetable iron. And this has got very important repercussions in terms of people who are vegetarians. And it is also pertinent and important to note that the fall in the blood parameters when somebody has got iron deficiency is the first parameter to show an effect of reduction is serum ferritin. Okay, so serum ferritin is the first one to fall when a mother has got iron deficiency, followed by serum iron, and the last to show any impact in terms of decrease is hemoglobin. So many mothers who are not anemic, if you look at the HB parameter, the hemoglobin parameter, may very well have iron deficiency already. Iron deficiency is the most common micronutrient deficiency in the world and affects 1/4 of the world population. And it contributes to 1/5 of maternal mortality worldwide and more than 20,000 annual toddler deaths. I take note just now when you presented the videos that one maternal death occurs every hour in Indonesia. And I think your maternal death is about 300 per 100,000 live births. And one perinatal death or neonatal death, I think, happens in Indonesia every hour. So that is quite high. And I think I'm happy to see that you are taking a lot of steps to try to reduce maternal as well as child death. And the effects of iron deficiency on pregnancy, what does it do? It results in maternal tissue enzyme malfunction because iron is a cofactor in many of the body metabolism. Therefore, it results in increased risk of preterm labor as well as increased blood loss at delivery, and this will propagate the iron deficiency more in those mothers after their delivery, you know. So with increased blood loss at delivery, it's going to be a vicious cycle. More mothers will have iron deficiency later. And not only the mother will now be saddled with, you know, perpetuated iron deficiency, but the iron deficiency in the mother will also result in fetal and neonatal iron deficiency, and this will be propagated in the child, resulting in anemia, decreased fetal iron stores, anemia in infancy, and very importantly, these children will grow up with behavioral abnormalities because there are changes in chemical mediators in the brain as a result of iron deficiency. You know, I always bring it to my audience in Malaysia that, you know, I wonder whether this is the impact of iron deficiency among the Malay ethnic group in Malaysia, because we see a lot more Malay youths, for example, being involved in drug addiction, you know, in our community. I don't know whether this can be due to this perpetuated effect of iron deficiency during their mother's pregnancy, okay? And more we are seeing an increased prevalence of adult hypertension in our community. You know, people as young as 19 years old starting to develop essential hypertension. Something must be wrong, you know, and possibly the fault is during the pregnancies that produce these children. So you can see here, deaths associated with iron deficiency anemia, you know, more than 20% affected, causing maternal deaths. And this is a study that we did in an urban district in Malaysia, in my hometown. And we find that almost half of the patients in that urban district has got anemia, and about half of these are due to iron deficiency. And the overall prevalence of iron deficiency in that community of pregnant mothers is almost 1/3, 31.6%. And very importantly is that among the subjects with normal hemoglobin, these are those without anemia. Almost 20% of them had iron deficiency. So this is a very important aspect for us to note. And so you do not have to wait until the hemoglobin level is low before the mothers actually have iron deficiency. This is something that perhaps many of us are not aware of, or we sometimes turn a blind eye. When we see a good hemoglobin level, we think that the mothers are healthy. In actual fact, they may not be. So up to almost 20% of them may have iron deficiency. And we find that the serum ferritin level correlated negatively with the period of gestation at booking, with 77.6% of these women with iron deficiency not having any prior iron supplements, which is why they have iron deficiency. And so those who book late in the 3rd trimester, for example, it is only then that they start their iron supplementation. And because of that, because they have not had the iron supplementation earlier, they are the ones with the low serum ferritin level. Okay, so this actually justifies giving antenatal iron supplementation. And we find that serum ferritin is significantly lower among grand multipare, among those of the Indian ethnic group. And at the end of the day, what we find is that the socio-demographic and obstetric factors, they are significantly associated with low serum ferritin or iron deficiency is one, Indian ethnic group, possibly because many of them are of low socioeconomic group, parity 5 or more, 3rd trimester late booking, and low educational level. This is the paper where we published our findings. And a related micronutrient when we talk about hematological aspects of pregnancy is folic acid. And folic acid deficiency is not far behind iron deficiency. It affects 1/3 of pregnancies. And the prevalence of this deficiency increases in those with multiple pregnancy as well as poor spacing of pregnancy. And maternal effects are tiredness, irritability, loss of appetite, fatigue, dyspnea, headache, GI, gastrointestinal upsets, and palpitations, not very different from symptoms of iron deficiency. And folic acid deficiency also gives rise to preterm birth, low birth weight, fetal growth restriction, and placental abruption. And the fetal effects include neonatal megaloblastic anemia, as well as fetal abnormalities such as hair lip, cleft palate, and neural tube defects. And in order to diagnose folic acid deficiency, the full blood picture and the RBC folate assay is what we would recommend. And the current recommendation for antenatal prophylactic supplementation of folic acid is 400 micrograms folic acid daily from at least 1 month before the pregnancy. And this is specifically in relation to neural tube defect prevention. But this is for prophylactic supplementation. Okay, for treatment of folic acid deficiency, it is recommended to give 5 milligrams folic acid daily. And in fact, in some sectors of the community, there may be conditions where pregnant mothers require more than 5 milligrams folic acid daily, notoriously or notably in hemolytic anemias, which is quite rampant in our population because we have a big chunk of our pregnant mothers with alpha and beta thalassemia and other types of hemoglobinopathies. All right. So these are hemolytic anemias, which will result in enhanced folic acid deficiency because folic acid is consumed in building the hemoglobin. All right, as opposed to iron. Iron doesn't get consumed and it is recycled in the body of these patients with hemolytic anemias, but folic acid is consumed. It is consumed and lost in the metabolism of hemoglobin. All right. So therefore, folic acid in these women need to be replaced faster than women without hemolytic anemia. So thalassemia traits, very important. The other very highly prevalent conditions which requires more than 5 milligram folic acid is in patients with obesity. It is, well, obesity is becoming like an epidemic as well in our population. In Malaysia, for example, 44% of the community is obese. Pre-gestational diabetes is also very important. Okay, these are established diabetes. Okay, those with chronic diabetes. I think in this part of the world, in South and East Asians, even by ethnic group alone, we are already a moderate risk community to develop diabetes mellitus. So again, you would need an increased supplementation of folic acid if you have chronic diabetes. The prevalence of gestational diabetes, of the prevalence of diabetes mellitus in pregnancy in our population in Malaysia here, just for the interest of discussion, is almost a quarter. In one study, it's 24.9%, as high as that. Almost 1 in 4 women in pregnancy has got diabetes mellitus. Zinc. Now, we move on to zinc. Zinc is, the significance of zinc is not so established, although there is some a study that says that deficient maternal dietary zinc intake is associated with fetal growth restriction as well as preeclampsia. However, there is not much evidence of the association between zinc in the diet with spontaneous preterm labor and gestational diabetes mellitus, and more research is required in terms of zinc relationship with outcome of pregnancy. DHA, which is a type of long-chain polyunsaturated fatty acid. The prevalence of DHA deficiency is very different from one population to another, simply because of the difference in the consumption of seafood. So in the COVID-19 pandemic, in relation to that, if it's true that women are taking less fish because of the pandemic, as evidenced by the study in from China, okay, which is not really surprising because, you know, a lot of the fish markets may close, people don't go to sea because of lockdown, and people don't go out to shop for fresh food because of the lockdown, okay, there may be a higher prevalence of DHA deficiency. And supplementation with DHA is said to be indicated if the average dietary intake of DHA is low. And the sources are from fish oil, okay, so basically it's fish and seafood, okay, as well as oil from algae. So, you know, a lot of DHA sources are from the sea. So if we are not getting enough seafood, or if you're vegetarian, you know, you'd better be aware that the prevalence of DHA deficiency may rise. And DHA deficiency has got impact on the infant cognitive development. In other words, the brain development. Okay, and it's important between in the early part of pregnancy, okay, in the first half of pregnancy. And one study found that the assessment at 4 years old using a measure of intelligence found that the test group which is given DHA supplementation performs better than the control group in terms of various aspects of mental processing composite. And DHA is also important for infant visual acuity, that means eyesight, okay, because DHA comprises 20% of the total fatty acid content of the infant retina, okay, and in terms of color vision, for example, it is important. And with regard to the mother, one aspect which should be highlighted is postpartum depression, because observational studies suggest that there is an association between postpartum depression and low maternal plasma DHA levels. So in this day and age when there is so much anxiety about COVID-19, and there's a lot of possibility of depression because of the pandemic that's happening, that is confining people to their homes, I think this is something that we have to pay a bit more attention. And it is found that women with delayed postpartum return to normal DHA levels had 10% higher risk of postpartum depression using the Edinburgh Depression Scale. And this is the recommended dosage in non-pregnant adults, 0.5 to 7 grams daily. In older people, actually DHA is also important because it reduces the development of Alzheimer. And in pregnant or breastfeeding mothers, the dosage recommended is 300 milligrams daily. And in formula-fed infants, if they are no longer breastfeeding, it is also important to have adequate DHA reinforced into their diet. Right, one very interesting micronutrient which has captured the limelight more recently is flavonoids. I think there is a lot more interest in flavonoids and perhaps increasing awareness about flavonoids in many people, although I do not see that being very much talked about yet among healthcare workers as well as the community. But it is very important. Flavonoids basically are polyphenolic secondary metabolites found in plants. Now, it is, we should be aware where flavonoids occur in the plants. A lot of the flavonoids are concentrated in the boundary between the skin and the flesh of fruits, okay? And because a lot of us, when we eat fruits, we tend to eat the flesh and we discard the skin, all right? Including the boundary between the skin and the flesh, which is not so tasty, okay? Many of us will, you know, shave off that part of the fruit as well. But it is very important for us to be aware that this is where a lot of the flavonoids reside, okay? And there are over 5,000 naturally occurring flavonoids that have been characterized from plants. For example, flavones from various herbs, anthocyanidins from berries and pomegranates, flavonones from citrus fruits like rutin, for example, isoflavones from soya like genistein, and also from legumes, kacang-kacang, okay? And flavonols from onion, from kale, from other vegetables like broccoli, and as well as drinks like tea, and flavonols from grapes, apples, and fava beans. So many are from fruits as well as beans and vegetables. And this is a study from a group in Malaysia, which I had the privilege of reading this study when it was submitted as a PhD thesis from University of Malaya. It was shown that low levels of genistein intake from soya bean were associated with an increased risk of developing preeclampsia. So these findings suggest a possible beneficial role of soya bean and genistein in prevention of preeclampsia. They looked at the intake of soya products like tofu, for example. Right. Last but not least, I would like to emphasize on the importance of multiple micronutrient supplementation. Each micronutrient may have its benefits, but when they are all put together, perhaps that is the ideal. And there are two studies that looked at this multiple micronutrient supplementation. One is the SUMMIT study using the UniMap formulation, and the MiniMap study looking at 15 micronutrients. Basically, if you look at the list, they are almost the same. So the SUMMIT study, you might very well be aware, is a randomized controlled trial that was conducted in Lombok in Indonesia. So I think many of Indonesian academics were also involved in this SUMMIT study. And it compared the supplementation of iron and folic acid alone with multiple micronutrients in that list that I showed you just now, okay, among a total of 30,000 pregnant women. And it was found that multiple micronutrient supplementation reduced early infant death, okay, by almost 20%, and it undernourished mothers by almost 25%, okay, and the reduced combined fetal loss and neonatal deaths was a magnitude of 11 to 15%, which is very significant. And it also reduced a low birth weight as an outcome measure of the pregnancy by 14 to 33%. This was published in Lancet in 2008. And in the MiniMap trial, which was a randomized controlled trial conducted in MATLAB in Bangladesh, in a group of more than 4,000 pregnant women, similar comparison between iron folic acid with multiple micronutrients supplementation, and they started early. One group started early at 9 weeks compared to a late start at 20 weeks. Okay, it was found that the early start with multiple micronutrients reduced infant mortality rate by about 60%. All right, and it reduced under 5-year mortality rate by almost the same magnitude as well. Okay, so it has been quite significantly demonstrated that multiple micronutrient supplementation, particularly in groups who are deprived of good nutrition, has got very good outcome. And this is a look at this cohort of Norwegian women recently who are taking a diet characterized by high intake of vegetables, fruits, and vegetable oils. And when they compare this to Norwegian women who are taking just the normal diet, okay, they found that this diet, which is rich in vegetables, fruits, and vegetable oils, have got increased risk of preeclampsia, okay, compared to the group with high consumption of processed meat, sweet drinks, and salty snacks. which actually increases the risk of preeclampsia. So two different ends of the spectrum. All right. So buy vegetables, fruits, and vegetable oils. I would think that a diet which is enriched in such a way would be rich in multiple micronutrients as well, because that's where a lot of the micronutrients come from. Vegetables, fruits, and vegetable oils. So in conclusion, macronutrients affect fetal gross growth, okay, the birth weight of the baby in the end. All right. If you have protein energy malnutrition, for example, you'll get babies who are low birth weight and small for gestational age. All right. And this can lead to problems also in the future for these offspring because of what is postulated in the Barker's hypothesis, more non-communicable diseases among them. Now, on the other hand, micronutrients play a big role also in improving pregnancy outcome for specific outcome measures. Okay, and the benefits of micronutrient supplementation are especially obvious in nutritionally deprived communities. And multiple micronutrient supplementation seems to be the way forward. It appears to be more significant than any single micronutrient supplementation. And very importantly also, when we talk about nutrition, is timely and adequate dose of nutritional supplementation. This will significantly improve the pregnancy outcome that is given this supplementation. Okay, the time factor is important when you give it during the pregnancy, early or late, as well as an adequate dose of the supplement. And that's the end of the second half of my talk, part 2. The third, in fact. There'll be another third after this. And I'll stop here for any questions and answers. You can see quite a number of things in the chat box. I pass over to Dr. Mata. Dr. Mata? Okay, I see some questions in the chat box. Right. I'll start from the end of the question just now. Okay, right. I think the first question is from Naintina Lisnawati. I'll read the question. Bagi Bapak.
Sorry.
Oh, right. Sorry, that is the
Sorry, Prof. Zaleha. Maybe Rizky will take over the MC. Prof. Zaleha bisa istirahat dulu sebentar, ya.
Oke, terima kasih.
Oke, terima kasih.
Iya, terima kasih Prof. Zaleha. Thank you very much for the lecture on the second third. Maybe kita akan ice breaking dulu, karena mungkin Prof. Zaleha juga sudah capek, J. Kemudian juga bagi peserta yang ingin menanyakan, bisa menanyakan di kolom komentar YouTube maupun di kolom komentar dari Zoom live streaming ini. Sebelum itu, untuk refreshing sejenak, pasti pesertanya juga sudah mulai capek ya. Kita akan ada senam yang judulnya cukup judulnya cukup kekinian. Jadi senam ini namanya adalah senam bebas corona. Akan dipimpin oleh Bapak Suroto. Silahkan.
Hi. Thank you. Yeah, I'm sorry. Yeah, I have a problem with the internet connection previously, so I will continue the discussion. Yeah, Prof. Zaleha, there is some question for you. Yes, you want to answer directly, Prof. Zaleha? Yeah.
Thank you, Dr. Mahdy. Okay. Well, the question says from Dina from Undip. Thank you for sharing the knowledge completely. I agree that protein is important for the health of the mother herself as well as for the fetus. In short, the fulfillment of nutrition for the mother is actually also a protection for the growth of fetus, correct? Yes, such as the need for metalloprotein to protect the fetus from heavy metals that are accidentally exposed to the mother. Do you have any research experience or experience in Malaysia regarding the effects of pregnant women on the risk of fetal growth due to heavy metals exposure? Right. I am aware that we have had a study on the exposure to lead in the environment. On exposure of pregnant mothers on lead in the environment many years ago, but I wasn't involved directly in the study itself. So I'm not too sure about the outcome. What I also do know is there was a study on dioxin, another toxin from the environment, on pregnant mothers' exposure to dioxin. And what was found was that, of course, what they looked at was dioxin in the breast milk of these mothers. And they found that there are significantly toxic levels of dioxin in the breast milk of mothers who are breastfeeding in certain areas, particularly in urban areas, because of the motor vehicle pollution, pollution to the environment, all right, from inhaling from the air and so on. So that is one thing which is quite significant, I thought, because if you do not protect these mothers from environmental pollution with dioxin, you will find that the babies will be consuming dioxin not from polluted bottle milk, but from polluted breast milk. So yeah.
Okay. Yeah, thank you. So there's a problem too with the this environment.
Yeah, that's right. Okay, from Ekawati, bagaimana pendapat Prof. Zaleha agar pekerja perempuan yang hamil dapat menjaga kehamilan sekaligus melakukan pekerjaan saat pandemi yang mungkin dapat meningkatkan kecemasan saat kehamilan? Right. Dan bagi perusahaan, apakah ada yang perlu dilakukan untuk melindungi pekerja perempuan yang sedang hamil tersebut? Right. Okay, this is in relation to COVID-19, right?
Yeah.
Yes. What I know is the Malaysian Health Service, as far as possible, try not to put pregnant workers at the front line. So if they are frontliners and they are pregnant, we'll take them away from being at the front line. We'll replace them with healthcare workers who are not pregnant. Okay? So that's one effort that you can do in order to protect pregnant mothers from the pandemic. And I hope that answers the question. From Afwandi, apakah ibu hamil harus minum susu hamil dan makan telur setiap hari? Berapakah sebenarnya kebutuhan susu dan telur bagi ibu hamil? Mohon penjelasan Prof. Zaleha, terima kasih. Dan apa manfaatnya susu dan telur bagi ibu hamil? Right. Well, in terms of the benefit, I would say yes, definitely. If you are not taking enough, if the pregnant mother, kalau ibu hamil tidak mengambil cukup kalsium dan vitamin D daripada diet, daripada elemen-elemen lain di dalam diet, maka mengambil susu dan telur yang cukup di dalam diet adalah sangat penting. Now, dari segi berapa portion susu dan telur, saya rasa mungkin pakar-pakar gizi di Undip sana mungkin lebih mahir dan berpengetahuan daripada saya, sebab saya lebih melihat kepada impaknya, tetapi kurang melihat kepada porsi-porsi yang sepatutnya diambil. Saya rasa pakar nutrisi lebih arif tentang ini. From Widya dari Malang, Profesor Zaleha, many thanks for your clear explanation. Alhamdulillah, thank you. I want to ask your opinion about the safety of liver consumption for pregnant women. Liver is often recommended to be consumed by pregnant women since it is high in iron, correct? However, I have read that liver should be avoided by pregnant women because the risk of overconsumption of vitamin A in the liver. I look forward to hearing your opinion about it. Thank you very much. Right. I think if liver is taken in the usual normal amounts in pregnancy, it should not be a problem in terms of overconsumption of vitamin A. Yeah, vitamin A, just like vitamin D and K, they are lipid-soluble vitamins. There is definitely E as well. There is definitely a risk of vitamin toxicity if you consume it too much, not like the water-soluble vitamins. But I cannot imagine any pregnant woman taking too much liver until, you know, the dose of vitamin A in the diet can become toxic, although the possibility is always there. And I think, of course, the advice of a dietitian in terms of the appropriate portion to be taken is important. However, there is another aspect of liver consumption that is also important to be aware of, which is the level of cooking of the liver or any other meat products in pregnancy. It is important that they are well cooked in order to eliminate any possibility of parasitic infestation, and also things like, for example, toxoplasmosis, you know, from contaminating all these meat products. I think that is also very important. They have to be well cooked if these meat products are taken by pregnant women. Just digressing a little bit. Okay, so I'm afraid in terms of the overconsumption, it depends on the portion, and the appropriate portion you have to depend on nutritionists and dietitians in order to advise you on that. Yes.
Okay, thank you so much for your answers, Professor Zaleha. Unfortunately, we have run of time, so we have to continue. Actually, there are still some questions from the audience, but please just we will continue first, and then maybe if we have time at the end of the program, then we can continue the question.
Yeah, I can take more questions after that.
Yeah. Okay. Please, yeah. Professor Zaleha, I'm sorry. This is the time for you for the presentation of part 3. Yeah.
Thank you, Dr. Mata. I will continue with part 3. Okay. Right. Part 3 has got to do with maternal nutrition in general issues, as well as the important question of obesity among pregnant women. Now, there are a lot of complications that can accompany obesity in pregnancy, and we are seeing a lot more of this in Malaysia. I would love to know how much is it affecting the population in Indonesia. Perhaps not as much as Malaysia, but still, you know, it may still be an important element. Maternal obesity aggravates certain diseases like polycystic ovarian syndrome, and perpetuates the infertility that is faced by patients who suffer from PCOS. It also increases the risk of diabetes and hypertension in pregnant women, as well as deep vein thrombosis. And it increases the risk of these mothers having to be delivered by cesarean section and all the accompanying complications, like, for example, postpartum hemorrhage and wound breakdown. And obese pregnant women are also more prone to develop depression, as well as breastfeeding problems. You know, they may have difficulty producing enough milk for their babies. And the healthcare cost of managing pregnant women who are obese is also higher because of the increased risk of complications that occur among them. And fetal complications that can occur with when there is maternal obesity includes things like fetal anomaly. Neural tube defect is one notorious problem. Maternal obesity doubles the risk of the fetus suffering from neural tube defect, like, for example, anencephaly and spina bifida. There is also increased risk of miscarriage and stillbirth, as well as big babies, macrosomia, and also small babies. Okay, so the two ends of the spectrum is more common among mothers who are obese. Okay, and there is also difficulty in monitoring the pregnancy. You know, when the mother is obese, not only is it difficult to measure blood pressure, for example, you know, it is difficult to palpate the abdomen and monitor fetal growth. okay, because of the thick abdominal wall. And there is increased risk of obesity in the children from such pregnancies as well. And these are some of the findings that we had from a small study that we had in Malaysia, 1,500 women in their first pregnancy. And there is increased risk of many of the things that I mentioned to you just now. Okay, diabetes, hypertension, eclampsia, postpartum hemorrhage, cesarean section, twofold increase, okay, wound breakdown, bigger babies. And sorry, just to make a note, this was a study by Dr. Yulianti, who was one of our the lecturers in our department previously. She was from Makassar. And if the woman underwent bariatric surgery, that means surgery to correct obesity, and after that she got pregnant, of course there will be less obesity related complications, but she would require special attention and support nevertheless, because of other potential problems such as volume restriction, okay, volume in terms of the amount of food that she can consume, okay, and she may end up with some degree of malabsorption, and she can also suffer from some emotional issues of needing to eat more to support a healthy pregnancy because of the lower capacity of her stomach now, because many of them undergo gastroplasty. What about the underweight woman? You know, those who are less than their normal body weight. This is a less common problem, but no less important, because underweight women tend to gain less weight than what is recommended. And this insufficient weight gain can be associated with multiple problems as well. For example, fetal growth restriction, perinatal morbidity, as well as perinatal death, and the effect of insufficient gestational weight gain on the birth weight of the baby is most marked in women who are underweight as such. And it can produce what we call the thrifty phenotype, which again is part of what is Barker's hypothesis, what Barker's hypothesis is all about. An infant who is deprived in utero of nutrition and then exposed to nutritional abundance after the delivery is more vulnerable to obesity with higher risk of developing metabolic syndrome, diabetes mellitus, and cardiovascular diseases. Okay, so this is something that we must all be well aware of in order to prevent higher healthcare costs in our population in the long term. Important issues pertaining to nutritional requirements in relation to pregnancy outcome is the preconceptional nutritional status of the mother, whether they are underweight or overweight before pregnancy. That is very important. So if a mother is not her ideal body weight before pregnancy, ideally she should be advised to optimize her body weight before she embarks on the pregnancy, okay? Particularly if she's obese. It's not easy, but at least, you know, some effort should be made in order to aim for that, to aim for ideal body weight before embarking on pregnancy. And the timing of intake of a certain element in the diet, particularly supplements, versus the phase of the pregnancy is also important. There are different needs nutrition-wise at different stages of pregnancy, as I have alluded to earlier. And so dosage and timing of supplements is important. And the interaction between pre and postnatal environment, which is what Barker's hypothesis is all about, is something that we have always have to keep in mind. So pregnancy and lactation are nutritionally vulnerable periods. These are periods which needs a lot of care in terms of the mother's nutrition. Okay, and in the preconceptional period, for example, nutritional problems can lead to infertility. In the first trimester, it can lead to miscarriage. In the fetal period, which is the second and third trimester, nutritional problems can cause pregnancy diseases such as preeclampsia and diabetes. It can also cause alterations of fetal growth like fetal growth restriction and macrosomia. And later on, in the postpartum period, it can also precipitate problems like depression as well as failure of breastfeeding. Right, a little bit on multiple pregnancy. Okay, this is a twin pregnancy nutritional recommendation. It is important to take note that there are certain requirements with regard to twin pregnancy or multiple pregnancy that needs to be taken into account for such pregnancies. It may not be exactly the same as in a singleton pregnancy. Of course, we don't say that the mother have to eat 2 or 3 times more than a singleton pregnancy, but of course the nutritional requirements, particularly the micronutrients, need to be handled with care. And this is one intervention program that was designed for these mothers with multiple pregnancy. Okay, in the first trimester, these are the things that are done for the mother, including assessment of the pre-gestational BMI and so on, and what are the specific weight gain goals of these mothers. Okay, what is the target gestational weight gain, and so on and so forth, and what is the specific requirement in terms of each of the elements in the diet. Okay, in the second trimester and also in the third trimester. Very importantly is counseling of the mothers as they go along during each semester, in each trimester, sorry. Okay, and so with that kind of regime, they have found that the nutritional status of the mother can be improved so much better. Okay, and the outcome of the pregnancies can be improved with such an intervention program. The red bars are the non-participant of the program, and the blue bars are the participants. So you can see that among the participants, the risk of having a very low birth weight baby or low birth weight baby and preterm birth before 32 weeks, as well as NICU, neonatal ICU admission, as well as major morbidities to the mother, are all reduced, okay, with the nutritional intervention program. Okay, so it is something that perhaps we can exemplify. What is the role of the nutritionist? It is not for me to say, but just some suggestions from the literature. Okay, for one thing, nutritionists has got more time and expertise than us obstetricians, okay, to address dietary issues. We have just that little time to see the patient when they come for antenatal care, and prenatal programs providing nutritional support for pregnant women have been associated with improved perinatal outcomes, as we can see from the Michigan Interventional Program on Nutrition. And individual dietary assessment and nutrition counseling is recommended for pregnant women with certain problems. So it should be individualized for those with obesity, inappropriate weight gain, teenage pregnancy. These are vulnerable groups. Multiple pregnancy, those mothers with poor dietary patterns, like maybe the mother who wants to eat too much liver just now, okay, and restrictive diets. Restrictive maybe because they are vegans, okay, or maybe because of restricted accessibility to good nutrition, for example, during the lockdown period, especially in the poor socioeconomic groups. Previous bariatric surgery may need special care, and recent weight loss, those with mothers with recent weight loss, pre-existing, like for example, those with anorexia nervosa, for example, okay, or pre-existing or current medical conditions, for example, diabetes, and eating disorders, okay, either eating too little, like anorexia, or eating too much, okay, like the emotional eating just now, all right? So this is where nutritionists can play a big role in counseling these mothers individually. And the pregnant mother should be advised to eat what she wants in amounts she desires and salted to taste. And we need to ensure the pregnant mother gets ample food to eat in socio-economically deprived women especially. And we need to monitor the weight gain in the mother with a goal of about 11.5 to 16 kilograms in women with normal pre-pregnancy BMI. And we also need to periodically from time to time explore the food intake by dietary recall in order to discover certain mothers who may be occasionally have a weird kind of diet, okay? So that has to be looked into. And supplementation wise, okay, iron salts is important, iron supplementation, as well as folate supplementation, and the rest like calcium and so on that I've mentioned in my talk in part 2. And recheck the hemoglobin or hematocrit at 28 to 32 weeks in order to detect any significant decrease. There is a strong place to say that vitamin D supplementation, for example, is also important, and maybe small amounts of some other vitamins, perhaps vitamin A or something like that. Okay, the most important, of course, is iron and folic acid and calcium. Okay. So in conclusion, you, in terms of the pregnant woman and your baby, are what to eat. This is what we should tell them. Okay. So watch your diet. Okay. We must always remind the pregnant woman about this. And we must also remind them that weight gain influences pregnancy outcome. So don't eat too much or too little. Pre-pregnancy maternal weight is an important determinant of the outcome of pregnancy. Nutritional requirements generally increase in pregnancy, much more so in multiple pregnancy. And micronutrient supplementation is generally necessary in pregnancy, particularly certain elements. And nutritional counseling is best done by a dedicated nutritionist, as in the Michigan study. So with that, that's the end of the third part of my talk. I thank you very much for your attention, for putting up with me for the long session today. Alhamdulillah masih belum repot lagi, masih boleh melayan soalan-soalan jika ada, insyaAllah.
Yeah.
So thank you very much.
Thank you very much, Prof. Zaleha. Yeah, it's been a long day today for you. Yeah, but your presentation is very interesting for us. I think, yeah, we all believe that your presentation is important for us, important knowledge that we have to know. Then in the pregnancy, what happened, yeah, especially during the pandemic condition and also during the situation like this. Okay, I just make a resume from your presentation, and then if after this, if we have still some chance to have a question and answer session. Yeah, so this in part 1 we have to already conclude, and in part 2 it said that macronutrient and energy protein requirements selama kehamilan itu dibutuhkan terutama untuk pada periode trimester kedua dan ketiga, ya, terutama pada trimester kedua dan ketiga, dan micronutrient supplementation itu juga menurunkan resiko IUGR, tetapi tidak berdampak pada panjang lahir dan umur kehamilan. Tetapi juga hati-hati juga dengan intake yang berlebihan dari sugar, ya, dari gula yang berlebihan itu ternyata juga menyebabkan preeklamsia, dan itu sudah diteliti, ya, terbukti oleh penelitiannya Prof. Zaleha, dan juga pada kalsium. Sekarang pada mikronutrien, ya, masalah mikronutrien ini juga kalsium supplementation yang menurunkan gestational hypertension, ya. Jadi suplementasi kalsium itu menurunkan tekanan darah pada saat kehamilan, juga preeklamsia dan angka kematian bayi maupun prematuritas. Asupan kalsium tidak dipengaruhi oleh ternyata kondisi situasi ekonomi, sosial ekonomi, sama seperti di Indonesia, saya rasa, ya, di Malaysia bersama, bahkan mungkin di Indonesia bisa lebih rendah asupan kalsium ibu hamil sangat rendah, dan ini berdampak pada banyak hal, ya, terutama juga untuk ibu, baik untuk ibu dan juga untuk anak, akan meningkatkan mortalitas anak bayi. Kemudian juga sebetulnya suplementasi kalsium pada trimester ketiga itu juga meningkatkan kesehatan tulang pada janin maupun ibu. Jadi ini sebaiknya juga dilakukan pada trimester awal maupun akhir, ya. Jadi terutama juga paling penting pada trimester akhir. Vitamin D vitamin D ini juga ternyata berkaitan dengan kejadian preeklamsia dan gestational diabetes mellitus, diabetes mellitus pada kehamilan, dan juga prematuritas SGA juga, dan berdampak pada fetus bahkan sampai dewasa. Jadi vitamin D intake ini juga penting, walaupun kita semua baik di Indonesia dan di Malaysia itu sebetulnya terpapar sinar matahari cukup banyak, ya. Kemudian dalam vitamin C dan vitamin E itu ternyata kalau diberikan bersama-sama, terutama yang vitamin E dalam bentuk tokoferol, itu mengakibatkan dampak yang kurang baik, ya, meningkatkan preeklamsia dan peningkatan preeklamsia dan juga adverse effect and fetal, ya, development juga pada fetus juga ternyata kurang baik. Dan tapi kalau pemberiannya dalam bentuk tocotrienol, ya, itu jenis lain dari vitamin E, ada dua macam. Tocoferol itu ternyata kurang baik, tapi penelitian Prof. Zaleha menunjukkan kalau diberikan dalam bentuk tocotrienol, ini merupakan antioksidan yang ternyata berdampak baik, ya. Jadi bahkan ini menurunkan kejadian preeklamsia dan sebagainya. Jadi yang menguntungkan adalah dalam bentuk tocotrienol yang pada penelitian Prof. Zaleha itu diberikan dalam bentuk bersamaan dengan palm oil, ya, minyak palm oil. Oke, kemudian pada folat defisiensi vitamin A, suplementasi vitamin A ternyata juga meningkatkan suplementasi A pada breast milk, ya. Jadi pada ASI itu meningkatkan vitamin A, dan juga ini akan berdampak baik pada ibu dan janin. Tapi tentu saja dalam dosis yang
kecil ya. Ya. Kemudian asam folat ini meningkatkan juga suplementasi asam folat itu. Vitamin A suplementasi vitamin A juga ternyata meningkatkan respon terhadap vaksin H1N1 ya ditemukan. Jadi sungguh sangat bermanfaat vitamin A ini. Ya, karena kita ketahui bahwa vitamin A ini penting pada imunitas ya. Kemudian untuk folat. Ya, ternyata folat defisiensi itu meningkatkan risiko low birth weight, IUGR, placental abruption, ya, kemudian meningkatkan kecacatan ya, neural tube defect dan juga bibir sumbing juga, kejadian bibir sumbing, sehingga asupan asam folat ini sangat penting. Nah, kemudian tentang besi, nah ini juga memang inilah defisiensi defisiensi besi ini memang paling banyak terjadi ya di dunia ini, dan juga berdampak berkontribusi banyak terhadap kematian ibu. Ini memang kita harus perhatikan, terutama di Indonesia kita masih punya angka kematian ibu yang tinggi, dan ini juga ternyata berdampak bukan hanya pada ibu, berdampak prematur pada janin, berdampak pada prematuritas, ternyata juga nanti berdampaknya pada sampai anak ini menjadi dewasa. Ada gangguan perilaku pada anak dan hipertensi bahkan pada anak yang dilahirkan pada saat dia dewasa. Luar biasa dampaknya ya. Dampak kekurangan zat besi. Kemudian juga DHA. DHA ini juga ternyata banyak manfaatnya untuk perkembangan otak dan penglihatan. Ya, kemudian juga flavonoid. Flavonoid itu juga masih kita perlu banyak menggali di sini. Ternyata flavonoid itu sangat bermanfaat juga, ya, terutama sudah dibuktikan juga dari genistein, yang salah satu flavonoid dalam bentuk genistein itu dari soya, dari kedelai, itu ternyata juga berdampak pada pencegahan preeklamsia. Ya, dan itu terutama pencegahan preeklamsia sebaiknya dilakukan sebelum usia kehamilan itu, bahkan sebelum 16 minggu. Jadi ternyata ada mikronutrien yang harus diberikan awal, harus diberikan akhir. Ya, memang ini perlu diperhatikan secara khusus. Dan ternyata suplementasi mikronutrien itu jauh lebih baik diberikan bersama-sama daripada satu persatu ya sendiri. Oke. Kemudian juga pada part yang ketiga, ternyata obesitas itu bermasalah, berdampak juga pada gestasional diabetes mellitus, pada gestasional hipertensi, pada preeklamsia, dan juga meningkatkan kejadian seksio sesaria, dan bayinya juga meningkat, dan tapi anehnya juga berdampak pada janinnya, bisa juga bahkan menyebabkan dia small gestational age. Ya, jadi dampaknya dua arah, bahkan yang berlebihan maupun jadi kekurangan untuk bayi janinnya. Ya, jadi obesitas ternyata juga banyak berdampak ya kepada keluaran kehamilan, Jadi sebaiknya sebelum hamil harus didapat berat badan yang ideal sebelum hamil, dan ada suplementasi yang harus dimulai sejak awal, dan sejak awal bahkan sebelum hamil. Ya, dan juga timing of supplementation itu perlu diperhatikan. Dan ternyata untuk mencegah small gestational age atau low birth weight pada multiple pregnancy itu juga sudah bisa dilakukan ya, dengan terutama mereka adalah kekurangan mikronutrien ya. Jadi nutrien supplementation-nya perlu diperhatikan untuk yang kehamilan ganda. Itu bisa diberikan sejak lebih awal, dipertimbangkan, dan juga yang makronutrien nanti dipertimbangkan sesuai peningkatan berat badannya, ya, apakah kurang atau lebih dilihat dari situ. Jadi pentingnya surveillance, nutrition surveillance pada ibu hamil itu sangat perlu dilakukan, dan juga peran nutrition atau nutritionist atau dietitian ini juga sangat penting pada ibu hamil, sehingga bisa didapatkan saran untuk asupan mikronutrien maupun makronutrien yang tepat, ya, tergantung juga pada kondisi-kondisi tertentu seorang ibu hamil. Ya, jadi itu yang bisa kami resumekan dari presentasi Profesor Zaleha. Sangat komprehensif, sangat lengkap, luar biasa. Ini sangat bermanfaat untuk mahasiswa kami maupun teman-teman dosen dan semua partisipan pada hari ini. Saya rasa itu sangat bermanfaat. Baik, kalau masih ada pertanyaan, silakan. Mungkin ada pertanyaan yang mau di-share. Ya, silakan.
Terima kasih Dr. Mata atas summary yang sangat bagus itu. I'm very impressed. Dan saya teruskan dengan soalan dari partisipan dari Samuel Adi. Apakah maaf?
Yeah. Maaf, Prof. Zaleha, iya, ini lebih dulu tadi ya.
Oke.
Ya.
From Respati Wulandari, fakta di lapangan masih dijumpai ibu menyusui yang mengkonsumsi minuman anggur merah, minuman fermentasi anggur yang dicampur ubat dan rempah yang mengandung alkohol 17 hingga 19% dengan alasan untuk melancarkan air susu ibu. Bagaimana menurut pendapat saya? Ini sebenarnya adalah lebih kepada, saya rasa, konsumsi minuman yang mengandungi alkohol semasa mengandung. I do not have any personal experience mengkaji topik ini, but I think dari segi konsumsi alkohol itu, saya rasa boleh dikatakan semua obstetrician akan kata perlu sangat berhati-hati kalau boleh dielakkan disebabkan masalah yang boleh berlaku disebabkan konsumsi alkohol oleh ibu semasa mengandung ataupun semasa breastfeeding. Transmisi alkohol kepada bayi contohnya boleh menjadi satu masalah. Lagipun saya tidak tahu apa impak alkohol itu kepada ibu berkenaan apabila mengambil alkohol yang agak banyak ini 17 hingga 19%, kalau ia boleh mengganggu kognitif pada ibu juga, ya. Jadi ini perlukan penelitian dari segi melihat kepada penerbitan ataupun kajian yang ada tentang isu ini. Maaf saya kurang arif tentang topik ini, tapi saya rasa perlu hati-hati.
Ya. Selanjutnya ya.
Ya. Selanjutnya daripada Samuel Adi, apakah dalam masa kehamilan pada trimester pertama kebutuhan susu untuk ibu hamil sangat dibutuhkan? Dan ketika masa kehamilan sudah mencapai 9 bulan, tetapkah butuh susu tersebut? Terima kasih. Okay, right. This is about milk consumption, tentang pengambilan susu, ya. Pengambilan susu seperti mana yang saya katakan tadi amat berkait rapat dengan kalsium, ya, dengan kandungan kalsium yang ada dalam diet. Dan seperti mana yang saya tunjukkan tadi, keperluan kalsium di dalam diet memang meningkat daripada semester pertama kepada semester ketiga. Okay? So, disebabkan di semester kedua dan ketiga berlaku perkembangan tulang bayi dengan sangat banyak. Oleh itu, keperluan kalsium pada usia kehamilan yang lebih lanjut memang lebih meningkat dan amat penting diteruskan. Soalan seterusnya dari orang yang tidak dinamakan, anonim. How about probiotic supplement for pregnant women? How important are probiotics for pregnant women? Right. Probiotic has been a topic that has been debated for a long time. Saya sebenarnya tidak cover probiotik secara khusus dan penyelidikan saya tidak begitu menjurus kepada probiotik. Jadi saya rasa lebih baik soalan ini ditanya kepada pakar yang lebih arif tentang probiotik.
Ibu Marta, mohon maaf.
Ya.
Karena waktunya sudah cukup siang, mungkin untuk pertanyaan yang lain bisa dikirimkan melalui email langsung kepada Prof. Zaleha atau sebagainya. Seperti itu. Mohon maaf, Jay.
Yeah, thank you for your answer, Prof. Zaleha. Because we are running of time.
Sure.
So yeah, if there are some more questions, then can they send it directly to you by email?
Sure, boleh, insyaAllah.
Yeah, thank you very much. Yeah, so this is the time for to end this presentation, this program. So we will give you a certificate and we will come back to the MC. Okay, Rizky, please. Thank you very much.
Terima kasih, Bu. Ya, terima kasih Bu Marta. Jadi Bapak Ibu sekalian, demikian pemaparan dan diskusi kita pada sesi ketiga ini. Sebelum acara ditutup, kami persilahkan kepada Dr. S.A. Nugraheni MKes selaku Ketua Panitia untuk memberikan sertifikat kepada moderator dan main speaker kita yang telah memberikan ilmu dalam acara ini. Kepada Dr. S.A. Nugraheni MKes kami persilahkan.
Maaf. Ya, terima kasih sekali Prof. Zaleha, the nice and excellent presentation. From the bottom of our heart, we would like to express our high appreciation for Prof. Zaleha, willingness to share knowledge. May Allah Subhanahu wa Ta'ala replace it with multiple kindness. Amin ya Rabbal Alamin. The following is a certificate as a thank you from us, Department of Nutrition from Faculty of Public Health Undip. Okay, thank you. This is a certificate for you. Thank you very much, Prof. Zaleha. Thank you very much from our deep heart, and I hope that in the future we can still work together. Okay, thank you very much, Prof. Zaleha. And then terima kasih juga untuk Bu Marta. Ini ada sertifikat untuk Bu Marta. Nice moderator. Terima kasih sudah mengawal kita untuk menjadi moderator pada hari ini. Semoga Tuhan juga memberi balasan yang kebaikan berlipat untuk Bu Marta. Makasih sekali Bu Marta.
Terima kasih.
Ya, terima kasih Prof. Zaleha. Izin bahasa untuk para peserta dan semua panitia. Saya terima kasih sekali dan tidak bisa membalas dengan segala dari lubuk hati terdalam saya. Terima kasih sekali, semoga Allah membalas dengan kebaikan berlipat dan bermanfaat untuk dunia akhirat kita. Terima kasih. Ya, sekaligus saya tutup ya. Mohon maaf atas segala kekurangan. Terima kasih semua. Billahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Ya, saya kembalikan ke Rizky. Ya, terima kasih Prof.
Iya, terima kasih Bu. Baik, demikian tadi acara Visiting Profesor bersama Profesor Zaleha hari ini. Tapi sebelum ditutup, dipersilahkan bagi seluruh audiens untuk mengaktifkan fitur videonya sejenak, karena kita akan melakukan foto bersama kali ini. Jadi silakan bagi audiens untuk mengaktifkan fitur videonya sejenak ya. Apakah sudah siap? Kita akan foto bersama. Oke, sudah siap? Foto akan kita mulai di hitungan ketiga ya. 1, 2, 3. Baik, sudah. Terima kasih waktunya. Baik,
Makasih
Bapak
ya,
Ibu.
Rizky.
Ya Ibu, terima
Iya.
kasih kembali. Baik, Bapak Ibu yang kami hormati, demikian tadi acara Visiting Profesor pada hari ini. Kami mengucapkan terima kasih kepada seluruh peserta atas kebersamaannya, dan juga thank you Profesor Zaleha, our main speaker. Thank you for the knowledge that was shared with us today. Terima kasih juga kepada Bapak Dekan dan Ibu Moderator, serta seluruh panitia yang telah bertugas pada hari ini. Kami mohon maaf apabila ada kata-kata yang mungkin kurang berkenan. Terima kasih atas kebersamaannya. Kami pamit undur diri dulu. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Prof. Thank you. Makasih semua. Assalamualaikum. Live ya. Makasih Bu Tina, Bu Asna, Bu Fat, Mas Eko, Mas Yuli, dan semuanya. Assalamualaikum.
Waalaikumsalam.